Hi, sir.
Hi,
Good evening. Thank you for joining,
good
sir.
evening. Good evening. No problem.
So just give us a
Are
couple
we
of
ready
minutes
to
more.
start? Yeah,
Sir,
sure.
just a couple of minutes more, sir.
Okay.
Thank you, sir.
No, we'll start sharp at 5. Yeah, Mehul, we'll start
Sure.
sharp at 5.
I have no problem. Please, no problem.
सर का इतना बड़ा भी आया व्हाट्सएप पे
ठीक है
और ये
हाँ,
Okay, so welcome back. Mehul, if you are ready, sir ta aa chuka hai. I'm starting. So we are on the second day of the 4-day overall program for the year in review for critical care. And people who have joined afresh, who are not there on yesterday, just to inform them, and also the newer audiences, as well as the panelists who have joined for the first time. We are usually we are doing it every year on the month of January, preferably in the second or third week. We got a little late this time. What we do is that we come up with the the overall whatever had happened in the last year, I mean the preceding year, in the field of the varied subspecialty field of critical care, whatever had happened. So be it in terms of innovation or a new research or a interesting publication or a technological update, new drug, whatever had happened in 24, as well as what we are anticipating a little bit on 25, maybe on the during the conclusion, we try to present it. That normally the presenters are youngsters who obviously collaborate with the experts and get the final list of inclusions. Then we also invite a lot of stalwarts who are the real experts in that concerned specialty. They give a little bit of their point of view, and the entire thing is moderated by a relevant person. So we already had covered a lot of on the transplant, clinical immunology, and others in last evening. So today we are covering mostly on cardiology, intervention pulmonology, extracorporeal therapies, and critical care imaging. So we'll start with cardiology itself, and the entire session would be moderated by Dr. Mehul Shah and presented by Dr. Pragya and Dr. Abha Dihinga. All of us are working with us in Sir H.N. Reliance Foundation Hospital. Mehul is the chief intensivist for the critical care department of critical care medicine itself, and he has got a immense experience in it. All of you know him, right? And he has trained in Australia itself before coming back to Mumbai. But today we do have a lot of senior person, and I would first invite Dr. Yatin Mehta, sir. And everyone knows, sir. Sir is the chairman of Institute of Critical Care and Anesthesiology in Medanta, and also had been the chancellor, the vice chancellor, as well as the president of Indian Society of Medicine. Welcome, sir. Uh,
Thank you.
we have, thank you, sir. We have Dr. Neeraj Kamath, who is a consultant cardiothoracic and heart-lung transplant unit of Sir H.N. Reliance Foundation Hospital. He is also takes care of a lot of the minimal for the mechanical circulatory support or the devices in our institution. He has mostly trained in the Department of Thoracic and Cardiovascular Surgery in AIMS itself, as well as he has done his training in Manchester in NHS Foundation Trust itself. So we also have Dr. Sandeep Katkade. He's a consultant of Department of Pediatric Cardiac Sciences with our hospitals. and his subspecialty is pediatric cardiac anesthesia. He has done his fellowship in Narayan Hrudayalaya, Bangalore itself. Along with, we have Dr. Hasbib Panthake. He's a senior consultant and chief of adult cardiac anesthesia in Reliance Foundation Hospital. He has done his training mostly in Mumbai and a couple of places outside India itself. We have Dr. Tapas Mandal, who is consultant in Department of Anesthesia and Pain Management, along with in our institute itself, HN Reliance Foundation. He has done his MD as well as his FRCA from UK itself, and more than 12 years of experience in cardiac anesthesia itself. And also we have Dr. Rohit, my good friend, Dr. Rohit Gunage, and he is the chief of anesthesia in cardiac transplantation and mechanical circulatory devices. So over to you, Mehul. You have a very illustrious and elaborate panel itself, and you have good presenters. So all the best to have a scintillating discussion itself. Thank you.
Thank you, Arindam. And I think
Mehul, your voice is little, I think not in the best of the shape. You may have two people simultaneously logging. Can you try once again? The voice?
Is it still echoing?
No, it's still echoing. I think one of you have to log out.
Sir, am I audible?
Yes, you are.
There is no background disturbance, right? So I'll just
None.
share my
But
screen.
you are not visible, Pragya.
Yes, sir. 1 second. I'm just turning on the. Sir, the slides are visible?
Yes. And it's full screen too. You are ready to go.
Yes, hi. And you can hear me. I think I've logged out of mine. So thank you all for joining. I think we've also got Bipin Chandra Bamre, who's joined us. He's a cardiac surgeon with us who's been working here since the last probably more than 10 years. And Bipin has done his cardiac training from Texas Heart and has been one of the leading cardiac surgeons along with our other teams, which comprises of Dr. Neeraj Kamath. I've tried to make this session in such a way that we'll have a mix of cardiac anesthesiologist, intensivist, and cardiac surgeons to help us across this cardiothoracic critical care review. And congratulate Pritima, Ketan, and Arindam, and thanks to Dr. Pandit for the opportunity. It's been a fantastic review so far, and I am looking forward to the rest of the day. So without further ado, I think I will let Pragna and Ava take over and start off with the presentations, and then we will add on to comments from all the respected faculty members. I think I also see Dr. Tapas Mandal, who has joined. So I think Tapas, Harvesh, Sandeep, Rohit, Neeraj, I'm not sure is going to be able to join. Sir is there, Yatin sir is there, and Bipin is around. Let's roll.
Sorry, I think the screen, as usual, at the last minute went off. Are you back?
You have Airtel connection or Jio connection?
Sir, what would your wild guess, sir?
Because I'm in the car and I've got a Jio, it is working.
Mehul, you should be. Sir has booked you right on the spot. right? So you get your things better in a shape. Oh, he has got, I think, locked up. So let me check. I will quickly go rush and check.
Yeah, I think we're back on. I think with the star-studded panelist, the computer went off by itself.
Extremely sorry for the technical glitch. So without further ado, we will go ahead and start the presentation. So we are going to discuss this article titled Prolonged Stay in ICU After Cardiac Surgery and the Challenges. It's a review article. Dr. Yatin Mehta is one of the authors. This article is published recently in April of 2024 in the Journal of Cardiac Critical Care. So this article basically focuses on the various reasons why we have a prolonged stay in the ICU in cardiac surgery patients, and what are the factors that are contributing to it, as well as what modalities or what preventive strategies that can be adopted to reduce the incidence of prolonged stay in the ICU. So, the definition of prolonged ICU stay, though there is no standardized definition that has been mentioned, a couple of retrospective studies have defined it as whenever your stay in the ICU is more than 5 days. And I think in our hospital also, on an average for cardiac surgical patients, our maximum stay is 2 to 3 days. The average stay in the ICU remains at 2 to 3 days. And so I guess prolonged ICU stay can be defined as more than 5 days. And the incidence of this is reported to be around 4 to 11%, varying based on the various factors. So the article has very beautifully identified various factors, and they are categorized as patient factors, surgical factors, and the post-operative factors. In the patient factors, the non-modifiable things like increased age, chronic obstructive pulmonary disease, insulin-dependent diabetes, renal dysfunction, patients who are under NYHA class 3 and 4, and who have a critical preoperative state in terms of cardiac function, as with low ejection fraction or history of atrial fibrillation. And if there is any incidence of delirium postoperative, are categorized as patient factors. And when we come to the surgical factors, majorly they include if the surgery is an emergency CABG or an emergency aortic dissection surgery, that is a non-elective surgeries, and the complexity of the surgeries, instead of just a CABG alone, if it is combined with a valvular surgery or if it is combined with coronary endarterectomies, and if the patient already had a prior cardiac surgery and it's a reduced CABG, and of course, the increased cardiopulmonary bypass time and need for inotropic supports intraoperatively are categorized as surgical factors. And post-operative factors, which are important from ICU perspective, as well as the surgical and the cardiology perspective, is post-cardiotomy ventricular dysfunction, which can significantly increase the ICU stay as well as the mortality of the patient. Non-occlusive mesenteric ischemia, new onset atrial fibrillation, acute kidney injury, and the very dreaded surgical site infections or a right ventricular dysfunction. So, what are the strategies that we can adopt to reduce the prolonged ICU stay? We majorly focus on ERAS protocols, as focused upon and emphasized upon in yesterday's talks. Also, ERAS is the thing of the future, and ERAS has beautifully given guidelines for every super specialty: gastro, surgery, cardiac surgery, general surgery as well. So in this article, they have focused on ERAS cardiac protocols to reduce the prolonged ICU stay. So we'll see in detail what the protocols are. And this is just a brief introduction slide of what ERAS is. It is an evidence-based, outcome-driven, multidisciplinary pathway that is made to maintain preoperative organ function and reduce the profound stress of the surgery, as well as optimize the physiological function and facilitate early recovery. The very basic pathway of ERAS is a referral from a primary center. There is a preoperative component, there's an intraoperative component, a postoperative, and a follow-up. So we are going to focus only on components that are specific to the cardiac surgery. So So first comes the preoperative optimization. So this includes two components. One is nutritional care and prehabilitation. At this point, I would like to call upon.
We like to ask some of our anesthesia friends. For example, if I'd like to bring in either Rohit, if you are there, or if Harvesh is there, if you all can throw some light on preoperative nutritional care and prehabilitation. But
Rohit here. Most
yes.
of our routine coronary artery surgeries, we do not look into it at the depth, but definitely the patients like complex cardiac surgery, CTPH, heart transplants, we evaluate them meticulously for their nutrition. We see upon all the lab reports, and we also take advice from the dietitians for a better optimization, because definitely these are the complex surgeries. The patient stays a little longer in the ICU, and in turn it helps the recovery. But yeah, as I said, not for all coronary surgeries, but for the complex cases.
Sure. I can get some view from the surgical point of view. If Bipin, anything with regards to prehabilitation of these patients or managements prior when they come and visit you, most likely they're always seeing you. So anything with regards to, for example, their HbA1c levels or smoking cessation and some rehabilitation exercises for respiratory or any of that?
Okay, definitely HbA1c for we do get it done for all our patients. That is mainly for the surgeons per se to decide about the conduits. But definitely we get it done for all the patients. The patients who are smokers, we if feasible, we delay the surgery for a couple of weeks and at least 2 weeks of abstinence from the smoking. Yeah.
Bipin, any inputs from your side? I think Dr. Bipin is also joined. Bipin, you'll have to unmute. All right, I don't see Bipin. All right. So our guidelines are very clear with regards to high morbidities with patients having a low albumin level, especially lesser than 2 grams. And, intensive nutritional supplements at least 5 to 7 days prior to surgeries would definitely help in building up their nutritional support and wound healing. Hemoglobin HbA1c levels of less than 6.5 have been associated with decreased complications, have also been studied with wound healing and lesser chances of myocardial ischemia. Yatin sir, any comment on this? Any comment on this prehabilitation? I'm not sure whether we get to see a lot of these patients prior to the surgery.
This all sounds very idealistic and good, but unfortunately, that is now how it's practiced at least in India. Prehabilitation in cardiac surgery is not that common, because half the time the cardiologist push for surgery, and no surgeon is likely to wait for weeks for a patient to get him into a better nutritional status. So let's be honest about it.
Okay.
What
So
at least we do at our place is that before admitting, if there are too many, sorry?
No, sir, please go ahead.
Before admitting the patient, sometimes when the patient has too many comorbidities, our chief surgeon refers the patient. And then I will send for everyone.
Right, sir.
Does agree if the patient is nourished, but the moment the frailty index is high, if he comes to me, I will start the moment I see the patient, at least, and continue post-operative.
Yeah.
Always the excuse is the patient is unstable and he can't wait for too long. But wherever you can, suppose it's a valve or double valve or triple valve and the patient is grossly malnourished, I would like to get him in a better shape before we get going with the surgery.
All right. Right, sir. Bipin, any points of yours on that?
So this is a very valid point, Mehul, regarding the prehabilitation, because we at HN Reliance strongly believe that the fast protocols what we follow in ICU starts from the preoperative patient education. So we have made it clear to the patients from the start of this program that all patients needs to learn about the physiotherapy, about the spirometry, and we also encourage patients to take good diet before operation. So yes, all our patients will have physiotherapy session, at least one session prior to surgery, so they also know what is going to happen post-operatively. Most of the bypass surgeries are elective operations, so we do get a chance to educate them before operation. So it really helps in the post-operative early recovery. Patient is ready, what is going to face, that is good for post-op care.
Right. All right. If I take it ahead with regards to certain other preoperative points, with let's again get Rohit, because I think Rohit and Harvesh, these are the two anesthesiologists who are there. Sandeep is also there. If you all can talk a little about your carbohydrate loading prior to surgeries and what are your experiences. The guidelines are very clear that a carbohydrate loading of 800 ml evening prior to surgery or 400 ml in 2 to 3 hours before induction has been shown to attenuate the catabolic responses with overnight fasting. So Rohit or Harvesh or Sandeep, if anyone can take that.
So if
Harvesh,
I may comment.
Yes, Rohit.
So, for the patients which I look after, it's been followed very meticulously since 2 years now. Initially, we just used to allow clear water to the patient, but as I noticed a severe metabolic acidosis in few of our patients, especially who were diabetic, then we have changed our minds to go with the carbohydrate drinks. Since 2 years, what we are doing is we are giving all our patients carbohydrate drinks before night, and just one more 350 ml of drink 2 to 3 years prior to the surgery. And even though I don't have a particular numbers or the data, but what I have realized is it's helping to a great level, to such an extent that the number of patients having metabolic acidosis has gone down significantly.
Definitely.
And definitely it's been followed.
Yeah, so that's a good point. Before I tell you, we've done a study on it. Before I take that, I'll take Yatin sir's opinion. Sir, what is your take and how would you talk? I mean, what is your take on the carbohydrate loading prior to surgery, and what are the practices that you would advise or would do? Yatin sir. Yatin sir. All right, I think sir has lost his connection.
See, we
So,
haven't actually, we are starting, but not yet
yes, sir,
in
yes,
cardiac
sir.
surgery. Not yet in cardiac surgery, and I think we should follow the same thing for cardiac is non-cardiac surgery, because we are not really operating on the abdomen and things like that. So I think gastric emptying is not really an issue. About
Sir, I think your connectivity seems to be a problem. Bipin, any you wanted to say something?
Yeah, so dietary wise, the patient should, that is also very important component to look after in the post-operative recovery. And I feel these oral carbohydrates have made difference in our experience in last 2 to 3 years, as Rohit has already said. I don't know what Dr. Sandeep opinion is that Sandeep is there.
Sir. Yes, sir. I am here, sir.
Please, what is your comment on this?
Yes, yes, sir. Yes, sir. So, as we know, keeping patient fasting for longer period of time can lead to catabolism and muscle loss, protein loss, and there are chances of starvation acidosis, we call it. So in pediatric patient, we follow that we give mother's milk 4 hours prior to surgery. We allow clear liquids. But adult, what we do is we ask them to remain fasting since overnight. Like the fasting goes beyond 12 hours. And we do find patients having hypoglycemia in the OT. And as Rohit has said, catabolism and postoperative metabolic acidosis is a common problem. So as everybody has said, we know that what ERAS protocol we follow for non-cardiac surgery. Same we are following for cardiac surgery also. Now we have started carbohydrate loading since last 2 to 3 years. And Dr. Keshri, one of our colleague, has done a good study on that.
Yes, so I'll touch on that study, Sandeep.
Yes,
I think
yes,
the results of that study were quite,
Bansi
they
Kondar.
were, yeah. So that study showed that we were able to reduce the incidences of metabolic acidosis and the ketosis that happened post-op. We all know that metabolic acidosis, along with hypothermia, will add to a lot of coagulopathy problems in a post-op, and is quite a challenging situation at certain times, especially in these high-risk patients who've got multiple grafts and redo surgeries, or high-risk patients. So definitely it did help to reduce the incidence of metabolic acidosis, but surprisingly, in our limited population, probably it's a limited center, it's one side, it's a single-centered study, and the number of patients were not that high. That's the reason why we couldn't get much of outcome benefits by reduction in the insulin levels or the units of insulin used when compared to other patients versus the length of stay. I think we've got good amount of slides to discuss, so I'll probably move on with the intra-op points. Quickly, if I can take Bipin. Bipin, if anything, you can talk about the intraoperative points which you can use for prevention or helping speedy recovery, like surgical site infections and all.
Yeah. So, of course, the most important aspect of prevention of surgical site infection, it again starts before the operation. So we have some protocols in place to do the MRSA screening and see if there is any problem. Some patients will have, particularly the female patients, with a lot of urinary tract infections. So we do the urine routine examination before operation and treat it accordingly. Then we use chlorhexidine based products to prepare the patient during the operation. Also, we prefer clipping as a method for our shaving, and then we give antibiotics that Dr. Sandeep and Dr. Harvesh will be able to tell in better way antibiotic policy in the operating theater. Also, tranexamic acid and all. Dr. Sandeep, can you elaborate on the antibiotics that we give during operation?
Yes, sir. Yes, sir. Definitely. So, as per our standard STS guidelines, we use antibiotic cephalosporin 1 hour prior to incision, and the antibiotics are repeated every 4th hourly. And as sir has already told, chlorhexidine alcohol-based solution, what we use Chloroprep or AHD solution to clean our patients. Even for putting invasive lines, we prefer a AHD solution, which is a chlorhexidine alcohol-based solution to prevent surgical site infection.
All right, we'll move on.
So the next component, the intraoperative component they discuss is they suggest to avoid hypothermia of temperature more than 37.9 degrees when the patient is on bypass and you're rewarming the patient. So any hyperthermia is associated with cognitive deficits, infection, and renal dysfunction. So even post-operatively also, any hypothermia within 24 hours is also associated with a cognitive dysfunction in the longer period followed in the post-op period of 4 to 6 weeks. So that is why they recommend avoiding hyperthermia. The next intraoperative component they suggest, the ERAS guidelines suggest, is going for minimally invasive cardiac surgeries, wherein a very small incision is given between the ribs, which is less painful and there is minimal blood loss. It has been shown to be associated with lower risk of complications, less discomfort to the patient, and they tend to be mobilized quicker as compared to our patients with a sternotomy. They do have a shorter ICU stay also, and a short-term hospital stay. Dr. Bamre, sir, can you please shed some light on the minimal access surgeries?
Yeah, so minimal access surgery is a good tool for the use, but its use is limited to certain anatomical diseases. Like in coronary artery bypass surgery, we use this if only anterior wall needs to be reperfused, like diagonal or LAD artery. So if such patient comes, then of course we will offer them minimal access, and the blood loss will be minimal. And the more important is the timing of the surgery. Shorter the surgery time, the infection rate will be less. So that is also there in minimal access. So it's short hospital stay, so less infection chances. So we are doing it sometimes for the mitral valve. And of course, the infections and other rates are very low. Early recovery is there in minimal access, but it cannot be extended to the all operations. Still, it is only particularly some indications that we follow for MICAS.
Agreed, sir. Thank you. So the next component it suggests is a rigid sternal wire fixation. And in the discussion that we had with our surgeons, I don't think it is something which is being practiced in our Indian scenario. But the guideline suggestion is that in high-risk individuals who have a very high BMI, had a previous chest wall radiation or a severe COPD and history of steroid use, they do advise for rigid sternal fixation with plates as opposed to our wire circlage. It has been noted that it causes better sternal healing and fewer sternal complications. Probably in the Indian setup, this is something which is yet to come up. And the next one is use of tranexamic acid to control the bleeding. I would like Dr. Harvez's input regarding this. Sir, how frequently do you use tranexamic acid or any other agents for controlling of the bleeding?
Yeah, so I mean, any kind of blood transfusion, if you can avoid, then there's nothing like it. So we all know that whenever there is any blood transfusion, you're going to be adding some kind of comorbs, I mean, a morbidity to the patient, and that is going to increase your ICU stay as well. So if you have an alternative to reduce blood bleeding by using something like tranexamic acid, which is used in the dose of say 10 to 20 milligram per kg, you can use it pre-operatively, you can use it on bypass, you can use it even post-operatively. Every 4 hours, if you repeat, it significantly reduces your bleeding, which is a well-known fact, and you can avoid blood transfusion based on that. Also, there are other techniques other than tranexamic or ESCA. You can probably use a cell saver in some beating heart CABGs or something, where you can probably use the patient's own blood, circulate it, wash it, and give it back to the patient. That also helps in reducing blood transfusion. Also, what I would like to add over here is blood transfusion in cardiac surgery should be point of care driven rather than a blanket rule where you want to just transfuse platelets or FFPs irrespective. Just because it's a pump case, you want to give them 4 platelets or 4 FFPs. That should not be done. You should do a thromboelastograph. Maybe based on the results of that, you take a call whether the patient needs platelets more or whether the patient needs cryoprecipitate or does he need FFPs, and accordingly take a call whether you want to transfuse or not transfuse.
Okay. Thank you, sir. So I think in our hospital, we do use cell savers regularly. So we do have lesser incidence of blood transfusions. So that concludes our intraoperative strategies that can be used to reduce the prolonged stay. Coming to the post-operative, one thing that significantly comes around always is the glycemic control, intraoperative as well as postoperative. It is suggested that maintain the sugar levels between 120 to 140 and insulin infusion is the most effective way. And I think intraoperatively also the anesthetist would agree that we regularly use infusions to maintain the sugar levels in that range. Next major component that comes is pain control. So intraoperatively as well as postoperatively, pain control determines your speediness of the recovery of the patient. There is this article that has come, like similar to antibiotic stewardship. They have published guidelines for opioid use perioperatively and postoperatively in cardiac surgery patients. They called it the opioid stewardship. I would request Dr. Tapas Mandal to shed some light on this topic.
Um, Thank you very much for this opportunity. So I would like to say that actually in terms of intraoperative and postoperative pain management, your planning should start right from your preoperative phase. Patient counseling is very important to realistically tell the patient as to what sort of a pain management the patient would be subjected to in the postoperative period. And in intraoperative period, of course, when we're talking in terms of opioid stewardship, earlier the practices were use of very high dose steroids. People used to use very high dose morphine or fentanyl or buprenorphine. But nowadays we have many shorter acting opioids also available, which have been used quite effectively in terms of fast tracking cardiac surgery patients, especially with the use of fentanyl infusions. And more recently in our institute also, we've started using remifentanil infusions. So it can be very easily titrated in terms of if used as a target control infusion and using it as a Minto model. So depending on the different phases, you can use it for intraop analgesia as well. And in the postoperative period also, as soon as you stop it, the patients can wake up within 5 to 10 minutes, actually, because it's got a very short half-life of 3 to 5 minutes. The other things which should be covered and which is normally covered in our institute also is they tend to use paracetamol for all the patients. Important component is what we call as the preemptive analgesia, wherein you start instituting the analgesia before the incision has taken place. So you can use magnesium, you can use lignocaine, you can use ketamine. Ketamine, if used as 0.1 to 0.2 mg per kg, 10 to 15 minutes before an incision is taken, it has got there's good evidence to suggest that it reduces the incidence of chronic post-surgical pain also, which can happen in cardiac surgical and thoracotomy patients. So in those cases, ketamine can be used. Dexamethasone has got a role as well in terms of intraop and postoperative analgesia. And of course, using any regional anesthesia blocks if possible. So if it is a minimally invasive surgery, you can also try using erectrospiny blocks or paravertebral blocks. Nowadays, in certain centers, I don't think so still practiced in our institute as yet, but people have started doing parasternal blocks as well. So that is an area which is coming up in the next possibly few years, and it can become a part of your ERAS protocols. One of the central things of an ERAS protocol, of course, is the pain management, which contributes to earlier recovery in the postoperative period because it reduces the stress response of the surgery. And an important part of that is to minimize the dose of opioid. So either we go to an opioid sparing anesthesia or we go to something which is called as opioid free anesthesia. Now that concept is also going further ahead. It is called as opioid free anesthesia and analgesia, wherein we are continuing the opioid free analgesia in the postoperative period. So that would include in the ICUs. So in such cases, lignocaine infusions or dexmedetomidine infusion or low dose ketamine infusion can also help. So this is how now the advances are being made. So chiefly we're talking in terms of shorter acting agents like remifentanil, dexmedetomidine, low dose ketamine infusion, and lignocaine infusions.
Right. I'll take post-operative delirium. We are having a lot of 20% of these cardiac patients post-operatively do develop a lot of delirium. And to be very honest, it's quite difficult with the CAM-ICU score for people to understand. But yes, it's an important marker for a long-term stay, and it does affect a lot of post-operative outcomes. Mehta sir, if Yatin Mehta sir, if you can hear us, sir, can you hear us? Sir?
Yeah, I can hear you. Yeah.
Sir, if I can get your inputs on the use of dexmedetomidine, even probably as we were talking as an ultra short acting agent and an adjuvant for pain relief, and probably we can advocate the use of the same in postoperative patients for preventing delirium. If you could throw some light on that, sir.
See, there are enough publications in the non-cardiac scenario regarding use of dex and reduce incidence of delirium, okay, as compared to the conventional analgesics or sedatives, and that should be applicable to cardiac also. I think it has been found. One of my students did a thesis on dexmedetomidine post-cardiac, post-op cap, and we did find earlier extubation and lesser incidence of delirium. We did assess with CAM-ICU. So there are not enough publications, but yes, Dex is a good drug to use, unless there is a contraindication for the use of Dex. That means the patient is bradycardic, or he's got a low ejection fraction, or he's on significant inotropes. Then you may hesitate to use Dex. But otherwise, many times we start the Dex infusion in the operating room itself, so that the patient goes smoothly to the post-op recovery, and then we start weaning the patient.
Right.
The patients
We are
who
also
need to extubate, that's what we do.
Thank you, sir. Thank you, sir. Just one quick point is there was this guideline which spoke about the use of a COX-2 inhibitor. Sir, any experience on using preoperatively a COX-2 inhibitor or even pregabalin as a preemptive preventive method for preventing pain post-op?
No, I don't have experience on that, but yes, I think it's a pregabalin. I would agree. It probably has a good possibility of, the patient remains a little drowsy. You don't mind that. But COX-2 inhibitor may have a little limited problem use in cardiac surgical, because see,
Right,
they have been shown to have certain side effects which may be detrimental to the cardiac function.
Sure, sir.
So
Sure, sir.
one should be also start using the transdermal patches. I think you get nowadays COX-2 transdermal also. You get which is called a new patch, or we use a lot of buprenorphine patches also, but because that lasts for 4 or 5 days, so we use a lot of that.
Right, sir. We'll move on, sir.
So the next component, that is preventing hypothermia. So we have to prevent hypothermia intraoperatively while rewarming the patient, and at the same time post-operatively when the patient is exposed, when we are doing the dressing. In those situations, we need to prevent hypothermia to make sure that the temperature does not go below 35 degrees. And routinely in the ICU, we do use forced air warming blankets and IV fluids to avoid that. The next component that comes is your chest tube patency. We do know that a lot of patients, whenever there is retained mediastinal blood, it can trigger an inflammatory process, and it causes atrial fibrillation. And what we routinely practice is either we regular intervals do milking of the drains, or we attach a negative suction to avoid any collection of the mediastinal fluid. But the major thing that the guidelines focus on is that remove the drains as early as possible once they become macroscopically serous. And I think we usually remove it in 1.5 days in our institute, and Dr. Bhamre would agree to that, I believe.
Yeah, so chest tube should be patent, and they should be kept patent rather in the post-operative period, so that there is no collection and then the post-op recovery is smooth after that.
Yes, sir. So the next guideline is extubation strategies. The guidelines suggest an early extubation within 6 hours of ICU arrival. And I think, like Yatin sir had mentioned, using of a dexmedetomidine infusion intraoperatively and shifting the patient to the ICU on that does, in our experience, also have shown that it has led to a smooth extubation. And we do sometimes extubate patients within 6 hours of ICU arrival. Again, kidney stress and AKI, Dr. Yatin, I would like your opinion on this. Do you actually use these renal biomarkers to identify patients at risk of renal injury?
See, I published a paper several years back on NGAL, urinary NGAL, and compared to serum creatinine as a biomarker for AKI incidence. And we did find that you catch it earlier. So you know what to do. You can you prognosticate, you can give some fluid therapy, some preventive measures. So NGAL is a sensitive biomarker, earlier appearance, but I don't have any experience with TIM2 and IGFBP7.
Okay, sir. All right. So again, general protective measures like avoiding radio contrast agents close to the surgery, maintaining good volume status, discontinuing
See,
ACE
can I come in?
inhibitors
One
prior
second,
to the surgery. Yes, sir.
I'll just come in once. the radio contrast injections, they peak at about 3 days.
Right.
Okay, the renal dysfunction peaks at about 3 days. So after
Okay.
you've done this angio or some other radio contrast study, if you have to, you can wait. It's a good idea to wait for 3-4 days.
Right. Agreed, sir. Agreed. So I think protective strategies remain the main hydration and preventive strategies are the major guidelines that we have. Next, coming to thromboprophylaxis, I think Dr. Mehul would like to comment on this.
So we did our brief catch up of our data, and we looked at our patients, nearly more than 2,000 patients that we had followed up retrospectively. And the ones who were given dual antiplatelet with early mobilization versus the ones that were given dual antiplatelet early mobilization plus DVT prophylaxis in the form of a low molecular weight heparin. And two things we found is there wasn't any major incidences of fatal P in between both the groups. A, there wasn't any major incidences of excessive blood transfusion secondary to the heparin. B, and even the excessive drainages or drains that would be probably increased after the dose of heparin given. So, Yatin sir, what would be your take on a chemical prophylaxis? Mechanical is what we're definitely giving. Chemical comes in the question when the drains are at a reasonable level and we've achieved good homeostasis and hemodynamic control. Between the use of dual antiplatelet plus early mobilization and dual antiplatelet with early mobilization and heparin. Any comments between these two?
See, that's a right question. I have published a prospective randomized trial, it's a PREVENT trial in NEJM. You must have seen it. I was one of the co-authors of that paper. It was in a mixed ICU, large number of patients, more than 15 centers worldwide. Yasin Arabi was the first author. And we combined prophylaxis, that means low molecular weight heparin with mechanical prophylaxis compared to only low molecular weight heparin. And we found no difference. Okay. So that has come in the surviving sepsis guidelines recommendation that we use, that is applicable to cardiac also, because we did a subgroup analysis of patients with poor LV function. Was there any difference between combined mechanical and pharmacoprophylaxis compared to only pharmacoprophylaxis? And we found no difference again in the subgroup analysis, which was also published as a separate paper. So combining the two doesn't make sense, in my opinion. There's enough evidence for that. What we start, you're right, when the chest tube drainage is not much, we start low molecular weight heparin the same day, in the evening. Sure, if the patient is done in the morning, we'll give it in the evening. If it's done in the evening, we'll give it next morning. So we started pretty soon, the thromboprophylaxis, low molecular weight heparin. Mechanical prophylaxis we use only when you cannot, because of some reason or bleeding or whatever, you cannot use pharmacological prophylaxis. Does that answer your question? Yeah.
Yes, sir. Yes, sir. Right, sir. We'll move on to the next one.
So we are just running short of time, but there's one just topic that I would like to have an opinion on is post-cardiotomy ventricular dysfunction. Yatin Mehta, sir, how frequently do you face this complication in your ICU? And later on, I would like Dr. Bhamre, sir, also to give his opinion on this.
Well, we do a large number of cases, and we do at least 2 cases every day, which have a EF of 25 or 30%. So we have a pretty good experience of this. It's not uncommon, particularly the pre-existent low ejection fraction. The ejection fraction doesn't improve immediately. So yes, we are probably the largest consumers of IABP. We put prophylactically, if the patient sneezes, also we put in IABP. Sometimes I say we put too many IABPs, and we use much less of ECMO than what we should be using for a post-cardiotomy heart failure. So I think these are the things which need to be taken into consideration. Main thing is to buy time. So if you are able to adequately support the heart with maybe IABP, which is less harmful than putting the patient on ECMO. But our mind should be open because our centers have the facilities for ECMO, and we should be using it more often. But you use the dilators and vasopressors accordingly to titrate them to a certain level, monitoring the cardiac function like cardiac output, whichever way you want to do that. And then if still it fails, then ECMO is the last option which you can use. But it'll have to be a VA ECMO in that case.
Yeah, so I agree with Dr. Yatin Mehta on this. The first machine, of course, if the patient has developed HV dysfunction post-operatively, we have a protocol in place to put the IABP immediately. And if there is associated right ventricular dysfunction also, then we go ahead and put ECMO as well. But of course, we have to further elaborate on why this dysfunction has occurred. And sometimes we have done CT coronary angiographies in case of bypass surgery to see whether the arterial blocks or some problem with the grafting and all. That also needs to be seen. If we have done a mitral wall or...
See, I'll just, Pragna, just...
Yeah, please, sir.
Yeah. Pragna, I'll just come in for 1 second. See, we have a hybrid operating room very close to the ICU on the same floor. So if there is new regional wall motion abnormality after bypass surgery, then we many times take the patient to the hybrid room, shoot the angio, and check which graft, if it all is blocked. And then the interventional cardiologist or the surgeon comes in to correct what the damage has been done, and further damage can be prevented. It has helped us save many lives.
Okay, that's great, sir.
Yeah, it's a very good to learn that we must do to prevent further damage, and if any correction is required, we should put the appropriate action in place. Again, if the dysfunction is associated with valvular lesions, then we have to perform the 2D echocardiographies and see if there is any problem with the valves. Sometimes we repair the valve, sometimes there can be paravalvular leaks, and it should be also treated simultaneously. Then the recovery of the patient also is better after that. So that's all from surgical point of view.
Thank you. I think ERAS in India is quite a distant speck on the horizon, and it's with a lot of heterogeneity in the practices which are there in our country. It will take a lot of great efforts to probably streamline them. Nevertheless, these protocols are not that rigid. They are quite flexible, and I think it's an important tool for everyone to know that we are thinking about important points preoperatively with nutritional rehabilitation, nutritional stewardship, then thinking of the points intra-op, how to help the patients to get better and minimize blood transfusion using adjuvants and modalities of surgeries and minimally accessed surgeries. And a good important point on postoperative pain management with regards to the use of adjuvants, things like dexmedetomidine, delirium prevention, and early rehabilitation and early mobilization of patients. And lastly, with the complications with postoperative ventricular dysfunction, and it's more like a multidisciplinary approach. And I think that's what we've tried to achieve today. Thank you, everybody. Thank you, Mehta sir. Thank you, Dr. Bipin. Thank you, Dr. Harvesh, Dr. Sandeep, and Dr. Rohit. Tapas, thanks a lot for a very short notice and being on the line. And we can leave this open to any questions if there are, or else I'm happy to hand the podium over to Arindam and move on with the next session. Any of us have any other comments, sir?
There is one question in chat box.
Oh, one second, I didn't see that. I'm sorry. In a postoperative patient, what are the key considerations of balancing the risk of bleeding with the need of early pharmacological thromboprophylaxis, and how do you personalize the approach for patients with high risk? Mehta sir, would you like to take this, or should I?
No, I think Mehul, we have answered a part of that.
We did answer
that
this
query.
question. Yes.
Yes. So I think if the patient is actively bleeding, then
Right.
pharmacoprophylaxis will have to wait.
Definitely.
You cannot
Definitely.
have it both ways, you know.
That's
And the
right.
patient who's bleeding, he's not going to make a thrombus in his deep veins. So I think you better
Yes.
wait till the bleeding is settled, and then you can look at the pharmacoprophylaxis.
Right, sir. All right. I think thank you everyone. I'd like to thank Ava. I'd like to thank Pragna. They've been fantastic with the presentation and with the slides. And back to Arindam for taking it further.
Okay, thanks, Dr. Mehul and all the panelists. So we move on to the next session on intervention pulmonology and acute care. So we have Dr. Gargi Moitro, who is a senior consultant in the Department of Pulmonology and Critical Care, as well as Intervention Pulmonology, Fortis Gurgaon. She is going to moderate. Dr. Suhas Dhulipala, who is junior consultant in Department of Pulmonology in Reliance Foundation Hospital. He is going to present, and we have two experts as informed as Dr. Sushil Bindru, who is Director Intervention Pulmonology Reliance Foundation Hospital. Also, Sushil had been my close friend for years, decades. He's also a trained intensivist. We have done intensive care together, and he has got a penchant for quality and clinical excellence. He is also the director of quality and clinical excellence in our institution. And we do have Dr. Paras Jain, who has very recently joined us as an additional director for critical care in Reliance Foundation Hospital. And before that, he had been in Australia for 2 decades with a background of pulmonology and practicing intensive care. So unfortunately, we have a couple of other people who couldn't join. If they join, we will quickly get on board. So Dr. Gargi, over to you. You can invite Dr. Suhas to initiate the presentation, and then you can take the expert opinions too.
Good evening, sir. I welcome you all to this interesting session on intervention pulmonology. So our speaker for this session is Dr. Suhas Dhulipala. And there are two topics that he is going to speak upon. One is ECMO as an aid in central airway obstruction. And the second topic will be VivaScope, the future pathologist. So I hand over the podium to Dr. Suhas Dhulipala to start the first topic, ECMO as an aid in central airway obstruction.
Good evening. I'll just be sharing my screen. I hope my screen's visible.
Yes.
So good evening. My topic for today would be the extracorporeal support as an aid for complex central airway obstruction.
Once again, Suhas, this is the VivaScope one that you have opened up.
I'm sorry. I hope it's visible now.
Yes, visible.
Yeah, thank you. So I'm Dr. Suhas Dhulipala, part of the pulmonary unit at Sir H.N. Reliance Hospital. Today I'd be speaking on extracorporeal support as an aid for complex central airway obstruction, which would be a case series. So now, as we know, a central airway obstruction can cause significant morbidity and mortality. Severe tracheal obstruction or stenosis leading to respiratory distress is a life-threatening emergency, and total occlusion of the airway will rapidly lead to death unless the obstruction is relieved. Central airway obstruction could be either malignant or benign. Malignant could be primary malignant tumors of the central airways or the bronchi, or extrinsic or intrinsic compression of the airways. Coming to benign, it could be of multiple pathologies, which would be most common is the post-intubation tracheal stenosis, autoimmune conditions, infectious etiologies, or chemical or thermal injuries. Now, how do we treat these central airway obstructions? The definitive treatment depends on the cause and degree of the level of obstruction, and which includes either debulking or a dilatation and or stenting. Airway management for these procedures is very challenging and may not be feasible due to severe hypoxia, ventilatory failure, or in extreme cases, shock and cardiac arrest. Secondary airway obstruction during a procedure can occur due to poor deployment of the stent or due to bleeding, tumor breakdown, or airway perforation, and can be particularly true for the removal of a metallic tracheal stent. So establishing the airway patency and restoring ventilatory flow is of utmost essentiality. Intubation may precipitate crisis or be impossible. Emergency tracheostomy or cricothyroidectomy may be life-saving depending on the level of obstruction. ECMO can be useful to secure oxygenation in severe cases of airway obstruction. Either we could use a VV ECMO or a VA ECMO based on present situation. Now, ideally, what would be the materials and methods that would be required? So all patients included in this case series had an initial emergent central airway obstruction diagnosed by a bronchoscopy or a CT, where extracorporeal support was used as an aid for the therapeutic bronchoscopy procedure. ECMO was indicated when the specialist felt that the conventional intervention was risky or impossible and would put the patient's life in danger following uncertain intraoperative ventilation and oxygenation, given the risk of complete airway obstruction or perforation or massive bleeding. So this requires a multidisciplinary approach, which includes anesthesiologists, pulmonologists, surgeons, transfusion technicians, and nursing care, along with critical care specialists. So all our cases, which I'll be explaining further, would require an intravenous line, an arterial line, a central line, which was inserted. ECMO support was set up in the operating room by the cardiovascular surgeons or the ECMO anesthetists prior to or during the procedures performed under local or regional anesthesia, sedation, or general anesthesia, depending on the patient's status and the choice of the anesthesiologist and the surgeons in the operating room. Patient's blood gas was analyzed regularly during the procedures. In all procedures, we used a heparin-coated ECMO circuit and heparinized serum to purge the ECMO cannulas. Now coming to my first case, which would be a grade 4 tracheal stenosis. It's a 26-year-old male patient who was brought to the emergency in the early hours with respiratory distress. As you can see to the right, you can see a small video briefing of a patient who was in complete respiratory distress. And on initiating of NIV post that, you could see that the patient still had respiratory acidosis. And the first thought that would come into most of the clinician mind would go on to put on to a mechanical ventilator and require a mechanical ventilation. But then, as his previous history suggested of prolonged ICU stay on the mechanical and ventilatory support for OP poisoning, his CT report suggestive of this showed a tracheal stenosis, suggestive of post-intubation tracheal stenosis. Considering his instability, the team decided to initiate on a brief VV ECMO support to aid in therapeutic bronchoscopy. Following initiation of the life support, his gas is stabilized. And if you can see the picture on the left was his prior to therapeutic intervention, his tracheal stenosis, which was a grade 4 tracheal stenosis on bronchoscopic examination, and post dilatation and silicone stenting showed the luminal patency was achieved. And post procedure, you could just see a small brief video showing the luminal patency which was there present. Now coming to the second case, was a 42-year-old female who was diagnosed with carcinoma esophagus and post-radiation therapy and underwent endoscopic guided Ryle's tube placement. Following the procedure, patient developed seizure activity and sudden respiratory distress, and an emergency intubation was done with a small ET tube. Her blood gas analysis showed the picture on the right, which showed a significant type 2 respiratory failure. Emergency pulmonary consultation was asked by the intensivist as he was not able to ventilate the patient. Diagnostic flexible bronchoscopy was performed with a thin scope with no success, as it could not be negotiated through the endobronchial tube as it was a small tube. Considering her severe acidosis, decision was made to initiate her on a VV ECMO. And once the ECMO was initiated, her gases stabilized. Then the bronchoscopy was done, which showed a narrow lumen and critical airway stenosis. Then post for a therapeutic management, a metallic stent was inserted and dilatation was achieved of the trachea, and the gas is stabilized. Then coming to the third case was an EBUS case where an 11-year-old young girl with known case of rheumatoid arthritis presented with complaints of cough, wheezing, dyspnea, fever, where chest X-ray showed bilateral hilar prominence and CT showed enlarged subcarinal, paratracheal, and hilar lymph nodes. Patient was posted for EBUS TBNA with differentials of lymphoma, TB, and sarcoid, underwent a biopsy from different stations. Predominantly, TBNA was taken from the subcarinal and 4R lymph node. Post biopsy, patient, the anesthetist was having difficulty to ventilate and unable to extubate the patient. An ABG was done, which showed a type 2 respiratory failure. Immediate bronchoscopy showed diffuse mucosal edema and airway narrowing. A VA ECMO was instituted by sternotomy via the aorta and right atrium. Mucosal edema decreased, saturation improved. By then, blood gases stabilized. ECMO was weaned off and shifted with mechanical ventilatory support and extubated the next day. It involved a multiple team effort over the next 16 hours with multiple specialty of doctors. Coming to for the last final case would be an endobronchial tumor debulking where a 30-year-old male presented with complaints of exertional dyspnea and stridor. CT scan showed incidental distal tracheal tumor, occluding almost 90% of the tracheal lumen as shown in the CT image here. And a brief X-ray shows a large polypoidal mass in the distal end of the trachea. So multiple attempts of snare polypectomy led to hypoxia, CO2 retention, and bleeding. Patient was intubated. Due to ventilation issue, necessitance for VV ECMO to maintain oxygenation was taken into consideration. Debulking success with ECMO support gave a complete luminal patency. As you can see, the picture below was the before and post. But one of the complications that was noticed during the procedure and post-procedure was developed hypotension due to a massive hemothorax that occurred during the cannulation of the ECMO and an immediate exploratory thoracotomy to remove the clots, almost 3 liters, and hematoma was noted and achieved hemostasis. 4 units of PRBC, 3 FFPs were transfused, IV antibiotics and inotropes were continued. ECMO was decannulated 48 hours later, extubated after 4 days and discharged. Follow-up bronchoscopy showed a complete luminal patency with complete lung expansion on chest X-ray. The team consisted of interventional pulmonologists, heart and lung thoracic surgeons, anesthesiologists, cardiac thoracic anesthesiologists, perfusionists, and multiple interventional pulmonary fellows, which worked for almost 14 hours in the operating room. And if you can see post the procedure, you can see the luminal patency was achieved. Now coming to just a small analysis of the 4 cases that has been shown here. The first case underwent a VV ECMO and the ECMO was removed on the same day. Second case was extrinsic compression where we did a balloon dilatation and metallic stent placement. Again, the ECMO was removed, decannulated the same day. And the 11-year-old girl who underwent an extrinsic compression due to mediastinal lymphadenopathy underwent ECMO decannulation the same day in the later night. And the fourth one was a benign tracheal tumor, which we placed a VV ECMO, was extubated the next day. The only complication noted was in the 4th case where we had a massive hemothorax with multiple bleeding manifestations. So my conclusion of this case series would be as ECMO is a life-saving and prompt initiation is needed in management of emergent central airway obstruction where intubation and tracheostomy are not possible for ventilation. It ensures adequate blood oxygenation, CO2 removal, and hemodynamic stability. Initiation of ECMO should be decided case-to-case basis. Use of ECMO with minimal anticoagulation was not associated with additional significant complications, again, based on operator comfort and stress levels. Thank you.
Thank you, Dr. Suhas, for that very interesting presentation on ECMO aid in management of central airway obstruction. I want to ask the organizers, should we take up questions on this one first, or do we finish both the presentation back to back?
No, you take Gargi, you take the questions here, because then people do get mixed up and all others forget too many presentations. You take the questions first.
Okay, sir. So, sir, my first question is for Dr. Manoj Goel, sir. Sir, so looking at the entire presentation, we know that we are using VV ECMO mostly as an aid in management of central airway obstruction. Sir, can you just further illustrate the cases where you would preemptively think of putting the patient on ECMO?
I think was a beautiful presentation. ECMO is something which is not much being talked about in interventional pulmonology. But it is definitely an aid because we are dealing with the airway which is severely compromised. The procedure may take a lot of time and may end up with complications like perforation, bleeding, and hypoxia. And that can be very difficult to manage. So I think if you have the facility and there is a critical airway narrowing, and the cases the type of cases that Dr. Suhas showed, I think it's better to preemptively put them on ECMO and then do the procedure. You will be comfortable, the operator would be very comfortable, the entire team would be relaxed and would be taking enough time to do the procedure appropriately. So it's a good idea. And we also did a case of a patient who was bleeding profusely, and he was a case of LVAD, and he had a clot in the trachea and in both the airways, and he was not getting ventilated. We got him on ECMO immediately, and then removed the clot with the cryo. So those situations where we are expecting a critical airway narrowing, which is potentially at risk, the procedure is going to be again risky. I think ECMO would be a good idea to have. But this is evolving technique. I mean, we are not talking too much about it, and I think this is something today. I think this chapter has up. Maybe the next in conferences on bronchoscopy, interventional pulmonology, we may be talking about more of ECMO.
Yes. So I think prior to this preemptively taking a patient on ECMO, we should do a proper evaluation of the CT scan, look at the level of the airway narrowing, do a flexible bronchoscopy, see how much of airway is left, and be able to judge whether we'll be able to intubate and ventilate the patient if emergency arises. So like sir has pointed out, preemptively taking up these patients on an ECMO instead of putting the patient's life in danger is a very good point. Sir, my next question is to Dr. Bindru, sir. So just to summarize, how does ECMO help in ensuring ventilation in these patients having severe airway obstruction? And also, is there any limitation we can face with ECMO in these patients?
So in patients with severe central airway obstruction because of the mass, so they have a risk of going into asphyxia. And when there is asphyxia, they go into type 2 respiratory failure, acute type 2 respiratory failure, wherein the CO2 will build up and the patient will be severely hypoxic, which can compromise the life of the patient. So these patients, what Dr. Manoj Goyal said, we should preemptively think to what you rightly said, do a checkscopy, see the CT scan, do a virtual bronchoscopy, do a checkscopy, and if we see that there is always a chance, the moment if we are touching the tumor, if it starts bleeding, the airway gets lost, and there's always a chance that they will die of asphyxia. So the best thing for them is to preemptively put them on VV or VECMO, depending on the hemodynamic condition of the patient. And so this will prevent the patient from going to complications. And even if sometimes they go into severe hypoxia, they can go into hypoxic-related hypoxic ischemic encephalopathy. And if we are able to circumvent that central airway obstruction, but then we will have a patient who is in a vegetative state. So it's better to do that in these patients. And so ECMO is a real handy and helpful in these conditions. The limitations of this will be the skill set which is required. You should have a center, we should have a backup of people who can insert large catheters. Like a pulmonologist will not be able to do. You need to have a CVTS surgeon or the anesthetist or the critical care specialist sometimes who can put in the ECMO. I'm an interventional pulmonologist, but I do know how to put the patient on ECMO. Then skill set, then the other thing is that if the patient is coagulopathic, then again, it will be very difficult to put the patient on ECMO. And then the other thing is that, these patients who are having active malignancy, they have got a lot of, coagulation abnormalities. They may be anticoagulants, they may be procoagulant, which can again block the filters and all of the ECMO and all. So these are the limitations to this. And then, ECMO by itself can have, various complications like thrombosis or bleeding, perforations. So these will be the limitation. But I feel that patients who have got a critical central airway obstruction because of the mass, and we know that it will take time to remove the mass by the ablation therapies, they should be preemptively put on ECMO. But then we should have a skill set, we should have a backup, we should have everything, we should have a good ICU backup, a good intensivist take care of the patient during the time the patient is on ECMO and the procedure is being deliberated.
Okay. Thank you, sir. And sir, also, would you like to mention anything on the site? Which veins, like, can we go for the IJV or go for the femoral vein if there's a central mass and maybe on the CT scan it is completely
I feel the route when we are doing the procedure, the route should be femoral rather than the
femoral vein,
IJV, because that will limit my field of action.
Right.
Because of these are large cannulas. So I will definitely go for a femoral. I will tell the person who is putting in the catheters to put a femoral till the time we are doing the procedure.
So go
So
for a
that I have free access
femoral.
so that I have a free access to the to my site of where I'm, because I'll be doing it from the head-on side. I'll be maybe using sometimes we might use a rigid scope. The position of the head has to be different while when you're doing a rigid scopy, and also I don't want a catheter here. I would just prefer to do a femoral cannulation in these cases.
So you would prefer a femoral VV ECMO?
Yeah, femoral VV ECMO.
Okay, sir. So, sir, another thing I was wondering, like you have already mentioned, a lot of these patients have bleeding problems, coagulopathy, tumors are very vascular. They start bleeding the moment we touch them. So, what kind of anticoagulant strategy would you like to follow while putting a patient on VV ECMO? Because if you are using heparin circulation, there is further bleeding, or if there is anything you would preemptively like to do for a tumor prior to going for an ECMO, maybe a bronchoalveolar.
So embolization will be one thing. So again, as I told you, if we should do a Jackscopy for all patients whom we are, preempting or planning to do a thermal ablation, because that will give us an idea of how vascular the tumor is, how far it is, whether it is fungating, it is vascular. See, they are all elective procedures, semi-elective procedures. So we have to prepare the patient also. So what we can do is, if the patient is severely hypoxic, we can just put the patient on ECMO. In the meantime, do a DSA of the patient, and we can do an embolization to decrease the chances of bleeding in that patient. So that is one more thing. If it is like patients who are having adenomas, they are very vascular tumors. So you can't just go in and start ablating the tumors. You have to do or serous adenocarcinomas. They are very vascular tumors. So, or patients who are having metastasis from hypernephroma, renal cell carcinomas, they have got endobronchial metastasis, which can be huge and can lead to can cause endobronchial obstructions, and they are really very vascular. So you should do a DSA and angiography in them, and SOS do a clog the vessels if they are very vascular.
And like, can you go for a heparin-free VV ECMO, because it's just for a short period of time and we expect one?
So again, I don't have much experience about the ECMO. That I will keep keep the responsibility of the person who is initiating and maintaining the ECMO. But I feel that the procedures which we do are mostly, but then if the tumor is big and if you're not doing a rigid scope and laser, then the duration of the procedure will be around couple of hours. So it will not be very advisable to keep them on a heparin free. Maybe that they might give intermittent heparin versus to maintain the patency of the lumen of these catheters. But if you are doing a rigid scopy, then doing a laser, the procedure can be done in around 30 to 40 minutes. All other thermal procedures will take more than an hour or two, depending on the size of the tumor.
Dr. Jain or Dr. Kaur, would you like to elaborate on the anticoagulant strategy during ECMO management in these situations?
Most of these patients will have a short duration ECMO time. No anticoagulation is a reasonable strategy. Most of the ECMO circuits have heparin bonding. So since procedure is just been done, there is always a risk of airway bleeding Most of these patients can be managed without anticoagulation for a period of time, and when it is safe, then low-dose anticoagulation can be started. But most of the time, these patients will have a short ECMO run, maybe a day or day or two. Yeah.
And would you prefer a lower level of APTT, like?
Yes, most of the time APTT range is 1.3 to 1.5 times, or
Yes.
anti-10A level of 0.3, 0.4 is reasonable for ECMO anticoagulation.
Okay, so maybe what I'm understanding is, if we know that the tumor is already vascular, we do a CT aortogram prior, do a bronchial artery embolization to reduce the vascularity of the tumor. And when we put the patient on VV ECMO, just give the bolus doses and then avoid the infusion of heparin, because in most of these cases, these are preemptive procedures, and we expect that maybe in half a day or 1 day, we should be able to wean off the patient from the ECMO and take him into the conventional ventilatory support. So, sir, I would like to ask Dr. Jain, sir, how would you want to wean the patient? Like, what are the parameters you would be looking at while shifting the patient from ECMO to a conventional ventilatory support? Anything you would like to look at particularly?
I think it all depends on the why ECMO was initiated. Now, in this patient, ECMO was initiated to perform the procedure and check see whether we have maintained the patency of the airway. I think in that situation, mainly to reduce the flow on the circuit, reduce the bias flow, and if patient is able to maintain with a minimal flow, then in that situation and able to manage on the conventional ventilation, usually patient should be able to decannulate it as long as there is a well-maintained patency of the airway and there is no obvious alveolar hemorrhage or bleeding that has happened immediate post-op or any complications, then patient can be managed on the conventional ventilation or invasive ventilation. Yeah.
Okay, sir. Thank you, sir. So just to summarize the points regarding ECMO as an aid in CAO, so I think prior to going for the procedure, studying the CT well in all the axial coronal planes, doing a check bronchoscopy to see what chink of airway is remaining. These are very important. Assessing the vascularity of the tumor, preemptively doing a CT aortogram and BA if is required, and take the patient on a VV ECMO with adequate cannulation site and minimal anticoagulant strategy. And do a check bronchoscopy post-procedure, see the airways patency has been achieved, there is no residual bleeding, and start weaning procedure. So would you like to add anything to this ECMO as an aid? Because it's a new topic for most of us and it's just catching up, but it's a very promising thing because when we land up with a central airway obstruction, it can be catastrophic. You cannot intubate, you cannot ventilate, and we don't want to reach that situation. Anything else you would like to, sir, add on to this? Dr. Bindru, sir, Dr. Jain, Dr.
Well, I think, Gargi, the point is very well taken. It's something that awareness of this is very important. Safety of the patient is extremely important. ECMO, is going to add to the cost around maybe 4 or 5 lakhs. It's an invasive procedure. So those things have to be taken into consideration. It's not widely available. Very few centers are there who can perform the ECMO. But you have got these more safety, better if you can do a bronchial artery embolization before the procedure gets to the safety. If you can take the patient ECMO, it takes a safety. The more safety measures you take, the more are the chances, you'll be able to accomplish the procedure better. But again, the cost is a very important issue, and the availability of the facility is also a very important issue. So say, for example, even for, bronchial artery embolization, you would need a thoracic aortogram, then you need interventional pulmonary radiology who is doing the procedure, then ECMO. So for things like this, I mean, it's too much for a patient to go. So if suppose patient has, where do we keep a balance? The important thing is this. Suppose the patient has got a tracheal tumor, which is vascular, causing severe compromise, right? Then you do it. But there is suppose less than 50% of the airway which is obstructed, you can minimize. So 50% less obstruction possibly you can do without ECMO. More, and again, depending on the patient's condition, more dyspnea, tachypnea, the kind of patient that he came, he showed with airway, with severe dyspnea, with, post-tracheostomy stenosis. So those are different cases. Similarly, if you have a lobar involvement, right major bronchus or left major bronchus, possibly you may not need these ECMOs. But tracheal obstruction, critical obstruction, stent removal, for example, where there could be a fracture, especially if fortunately we've got the stents which can be now easily removed. But the earlier times it was a very difficult scenario to remove the stents. So these are the questions we have to sort of keep a balance, keep the cost, availability of the facility. All these have to be taken into consideration.
Okay, sir. Thank you, sir. So I think we are ready to move on to the next topic for this session. And the next topic will also be spoken by Dr. Suhas Dhulipala, the future pathologist Vivascope. Over to Suhas.
So I think my next topic is going to be a real game changer in the coming few years. Hope my screen's visible.
Suhas,
Yes.
I think your voice is little, I think not voice, I maybe the audio system is little difficult for the audience. A lot of people give a feedback.
Yeah,
So can you please turn up your volume?
Yes, sir. Sure, sir. I hope I'm audible now.
Marginally better, but you can still do good on that. I think Gargi, do you agree? His volume is little lower. Yeah. Or maybe you can be a little more aggressive in presenting that. I know you are a very shy person, but you are doing very well. So please, if you can speak a little louder, it could be your problem with the laptop
Sure, sir.
itself.
I'll do that.
Okay, thanks.
So I think my next topic would be a real game changer in the coming, at least hopefully in the coming months to years. So I would like to call this topic the future pathologist, the Vivascope. So are you ready for a change? Here it is. This is a small piece of biconical microscopy which can be put any corner of your hospital or your operation theater or on your floor, which is going to be a real game changer. So what is a Vivascope? It is a diagnostic tool providing high-resolution histopathological images of desired tissue samples in less than 5 minutes. It allows rapid microscopic tissue analysis and directly yields digital images ready for telepathological application. This tool expedites the process, minimizes the duration needed for the diagnosis. The samples obtained in all these cases are adequate for histopathological analysis and immunohistochemistry. The results obtained with the help of a Vivascope are superior in quality, compatible in nature, and with the conventional microscopic image with the advantage of rapid diagnosis within minutes. So how do we go about it? How does this process work? So how do you stain it? So the steps of staining procedure for the Vivascope, if you can see on the small image on the right side. One second. Yeah, if you can see the small image on the right side is a cytomatrix. It consists of a positively charged mesh, which needs to be charged before obtaining a sample on it. How do we charge the mesh? By dropping 5 to 7 drops of 70% ethanol on the mesh. Step 2 would be obtain the biopsy sample on the positively charged mesh of the cytomatrix. Step 3 would be fix the sample using 70% ethanol for around 10 seconds. Then we add acridine orange for around 30 seconds. Then we use fast green staining for around 20 seconds. Then we repeat the same steps 3, 4, 5 for 2 to 3 times in the same order. Then rinse the sample very carefully using a 0.9% normal saline to wash off the excess stains. Now, yes. Step 8, the biopsy sample along with the cytomatrix is loaded onto 2 glass slides with strong magnets on both of them. The idea of using the magnets is to achieve flattening of the tissue and ensure the integrity of the sample is maintained. Now the sandwich cytomatrix with the biopsy sample is ready to be loaded on the Vivascope 2500 for scanning. So here, what is a Vivascope? What is it composed of? So its components are mainly 2 different lasers of different wavelengths to create 2 distinct images, a fluoroscopic fluorescent one and a reflectance image. Both signals are scanned simultaneously and are used to create pseudo-colored images. The device software uses an algorithm to translate the acquired image information into the colors that resemble that of H&E. Now, if you can see on the left side are the VivaScope images, and on the right side are the conventional histopathological examinational images. So again, just to brief up, it is the first step would be tissue removal, then comes the staining procedure, then comes the tissue mounting like we put it on the slides with the magnet. Then we do the confocal imaging, and then the evaluation and telemedicine, where we call the pathologist to ask them to review the images and give us a diagnosis within 5 minutes. Now, what are the advantages of the VivaScope? I think it needs minimal preparation, no need for an on-site pathologist or a specialized cytotechnician. It's remote evaluation in real time, possible even via telemedicine. For example, if your pathologist is not in-house, you can send him the pictures over WhatsApp and ask him to give his opinion. Full-time preservation for further post-operative analysis without damage or loss. Advanced patient care by reducing the number of needle passes if it's an EBUS or an EUS, and associated risk of adverse events are also comparatively lesser. Optimized resource allocation by minimizing the necessity for rebiopsy, and efficient patient management by immediately initiating the treatment schedule. Where all can the VivaScope be used? As in pulmonary medicine, where we use our EBUS-guided biopsies, or gastroenterology, interventional radiology, organ transplant, urology, dermatology. So what is the conclusion of this? The whole presentation, I'd say, is a confocal microscopy is a valuable tool for rapid on-site evaluation, offering real-time, high-resolution imaging that enhances the speed and accuracy of diagnosis. We propose that the conventional rapid on-site evaluation will be replaced by rapid on-site digital histopathological evaluation for sampling, provided a quick diagnosis in less than 5 minutes. Thank you.
Thank you, Suhas. This is a very new topic, at least for me. I have no personal experience for this. And this looks like very promising, and it should be a game changer in near future. So, sir, my question to the panelists, all the panelists, sir, like Dr. Bindru, sir, Dr. Goel, sir, Dr. Jain, sir, has any one of you have personal experience with this method?
No, I don't have.
Okay, Dr. Jain, sir.
No, I don't have.
Dr. Arindam Kaur, sir. Or maybe Dr. Suhas.
Yes, ma'am.
Can you elaborate on this?
So now if we're in the intraoperative period, we're looking for a diagnosis for, I can say, pertaining to pulmonology, we go to multiple stations of the lymph nodes. We do multiple biopsies, especially when we're doing a staging EBUS. We have to look for each and biopsy, where we say the guideline says take at least multiple of 3 biopsies per pass, per station. So here, if we take a first station and we use it within 5 minutes, we know what our diagnosis is, instead of us going to a stage 2, repeat multiple sampling, repeating number of biopsies. That is one benefit. And when it comes to surgical oncologists, to see the margins of the tumor, especially for them to go, how far do they extend to go on for their excision biopsies. I think this is also going to be a rapid change for the extent and preventing more excessive excision biopsy.
Suhas, Gargi is saying whether you have any personal experience with this.
Yes, so ma'am, we had a brief, it just recently launched for last 6 months in my previous center. We've used it as a trial basis.
Okay.
And it has been quite
useful. I think the advantage I would say of this is that you are not fixing the tissue. I went through the literature about it. I have not seen it personally. I am planning to go to Hyderabad next month for a talk, and then I would meet, where Suhas was earlier. I think the best advantage is time is, you can do the procedure in less than 5 minutes, but then when you're doing a procedure, you can still wait for some time for the, ROS and wait. But here, the best thing is that you're not fixing the tissue. You're just staining the tissue. So if you get the diagnosis of malignancy in these patients, you can, on the ROS, you are fixing the tissue, formalin stained and all. So you lose the tissue, then you have to again go and take the biopsy of the tissue. Here, you can use the same tissue for further immunohistochemical or immunologic typing, because now we know that we have a myriad of investigations or immunohistochemistry stains or immunostains available for further finding out the mutations, so that, because we are in the era of now immunotherapy and all those things. So here you don't have again to poke the patient and take. So the duration of the procedure, one, the number of passes taken, the number of nodes to be sampled or number of lesions to be sampled will be reduced, except that when you are not doing the staging of the tumor. So that is one advantage I could find about that, because it creates that what is a confocal microscopy. It creates the same staining effect as you are doing H&E staining. So that is the advantage what I found of this new diagnostic method.
I don't know if we are at a stage to answer this, but I was just wondering, so is there a possibility of discrepancy in the final reporting between what we are seeing with this method and the final histopathology report after the final staining and processing?
So I went through the literature and I found that there was a large multi-center trial done regarding this to interpersonal agreement, interpersonal observational agreement, and then between the pathologist, the histopathologist, the pulmonologist, and they found that there was not much difference between the two. Even you are a conventional method of ROS is as sensitive and specific as this one, or this is as sensitive and specific as this one. The only advantage is that the time taken is less. It is just less than 5 minutes for doing the entire procedure. And the second thing is that you are preserving the tissue
And
for future immunohistochemical investigations.
Okay, sir. Sir, do you feel there's any limitation to this method?
So again, because it is a machine based, I think there's too much less of an experience with this. So I don't know in the Western countries how much they have used it, but I think in our literature it has come since what Soha said, maybe a year or two, not before that. Definitely post COVID. So again, it will take some time to see the difference. What are the limitations? The limitations, see, they are mostly the wavelength based, the AI based algorithm is algorithm based technique. Okay, it is not a manual technique. So algorithms can this it's still not proven. That I told you that there's only one multi-center study done till date since it has been launched, wherein they saw that the inter-observer agreement was good. But then how we will be able to perceive, it will take time for us to take, as you rightly said, it's too early to say how sensitive and specific it will be when you are doing multiple head-to-head trials between this and the conventional technique.
Right.
But for the time being, it appears very promising because the time taken is less.
Less.
The tissue histology is preserved. And what Sohas rightly said is that in the cases when you are doing a surgery, the end margins to see, it is very quick for the surgeon. But because the ROS takes a lot of time to do the HE staining, fixing up the tissue, it can take up to an hour or 30 minutes. But here, within 5 minutes, you know that what you are, whether your margins are clear or not. But when you are taking the large samples, when you are seeing, because it is based on some algorithms, how accurate it will be, it will take still much time for us to reach a conclusion.
Sir, like its scope and usability in intervention pulmonology, like where do you see it developing in coming years? Like in transbronchial lung biopsy, endobronchial lesion, sometimes a fungating mass could be a fungal lesion, like we see in so many cases of mucormycosis, which can resemble a tumor-like lesion. If we get an on-site evaluation, then we don't need to remove it and maybe just stick to conventional antifungals. How do you see this will help in intervention pulmonology?
I personally feel that ROS is mainly done for the diagnosis or exclusion of malignancies, lung cancers.
Yes.
Okay, so staging of lung cancer, it will be very effective. Because if you are you have a N3 node, you have a lesion on the right side, you have a N3 node on the opposite side, you take it, you find it, you are saved of the time. The procedure can be as good as done in 15 minutes, right? Otherwise on ROS you have to do multiple passes and all those things. So one is the staging of the tumor, it will be very effective. I personally feel that mucor and all, by the hue of the tumor, the gross hue of the tumor and the general condition of the patient, mucor patient is they'll be very sick. they do normally reach the level wherein it's a cavitating, rapidly progressive lesion. They might present as fungating lesions, but they are very significantly black color. The patient will be hemodynamically unstable, and they will be very hypoxic. But I feel all EBUS guided procedures or all EUS guided procedures, staging procedures, diagnostic procedures, they will be the conditions or the circumstances where vivoscope can be of use.
Okay. Okay. Thank you, sir.
Because anyways, for the diagnosis of mucormycosis, you need a stain. You have to find out a fungus in either the histopathology or the microbiology. You can't otherwise. You have to give the treatment for that.
Okay, sir. Thank you, sir. Thank you for that very informative discussion. This is a very new topic for me, and I believe for majority of us. And I think this is going to be a game changer in near future.
Absolutely.
So I think we have any more questions?
I think you can also see the chat box, Kargi.
I think there was only one Ashish.
Will it be
Sohilji,
safe?
to wean from
Will it be
conventional
safe?
ventilation prior to ECMO in given emergency? Yes, because
Sir, can you unmute yourself, please?
So I said this is a very good question. So I think that if these the mass which was causing the central airway obstruction has been dealt with properly, and we have been able to obtain or secure the airway, we have been able to remove the tumor, then we can remove the remove the patient from the ventilator earlier than the ECMO. ECMO will be done basis on the basis of the hemodynamic stability of the patient, and also the first thing definitely would be to remove from the ventilator and then remove from the ECMO. That's it. Because we have already the basis of removing the patient from mechanical ventilation is that you have treated the cause which had led to the mechanical ventilation. If the cause of putting the patient on mechanical ventilation was a central obstructing tumor, airway obstructing tumor, and we have removed it, then there is no other reason that the patient will need a ventilator.
Okay, sir, I think there is no more question in the chat box. Sir, I think we have come to the end of this session. Sir.
You can summarize and give a sort of abbreviated view from your end.
So,
And
sir,
otherwise, we will also move. Yep.
Thank you, sir. So, Dr. Suhas, thank you for these two very informative talks. ECMO is still catching up in the field of intervention pulmonology, and we come across this problem of central airway obstruction every day in our practice. And when we are aware of the use of ECMO in CAOs, we will be much more wiser, and we can take decisions better and prevent any emergencies from happening. And also this next, the vivascope, only time will say, and I hope looking at it, it looks pretty promising, and I think it's going to be a game changer over the next few years. So I'm looking forward to using it.
Yeah.
Over to Kaur, sir.
A special thanks, because I didn't thank him, to Manoj Goel, sir. He has always acknowledged my invitation. Thank you, sir. And it is always nice to have you and your expertise on board. Thank you, Dr. Sushil. Thank you, Dr. Paras.
Thank you.
Please stay with us. We have a couple of other interesting, if you really do have a little time from your busy schedule, you can continue. Because our next session is on extracorporeal therapies, an extension of what we discussed today. And to present that, we have Dr. Prithima and Dr. Vikrant Pawar. Both are senior consultant in critical care medicine, Reliance Foundation. And to moderate, we have Dr. Venkat Raman Kola. And
Good evening.
Venkat is a good friend. He's been the vice president of ISCCM. He controls the entire Hyderabad. In fact, I won't exaggerate that he owns that entire zone of Telangana in the critical care, right? He runs the biggest sort of conglomerate of critical care practices practitioners, and he has got a very nice brand new ICU to take care of in the Hypercity. So welcome, my friend. Thank you for coming despite your very, very busy both clinical and academic schedule. And we have on the panel of experts, we have Dr. Professor Rahul Pandit sir, who is the chair and director for Critical Care Reliance Foundation Hospital. My friend and colleague, Dr. Arpan. I think Arpan Chakravarti, everyone knows by this time, one of the leaders in the ECMO services in India. He has done, if not one of the maximum number of good ECMOs in the country itself. Dr. Munish Chauhan and Dr. Pooja Wadhwa, both from Gurgaon, and both very good friends. And all of them had as a significant contribution on extracorporeal therapies itself. So over to you, Venkat. I think Vikrant would be presenting. Pritima has a very bad sore throat. She is here, but mostly I think Vikrant is going to speak on it. So over to you, Venkat. You ask,
thank you.
invite others, and then you moderate the entire session.
Thank you. And it's an opportunity to interact with sir and the all team. Thank I think all are there on board. I hope all of them are on board. Arindam sir, all the panelists are on board.
Arpan, sorry, I can see Arpan. Pandit ji is there. Yeah.
So, good evening.
I'm here, present.
Good evening,
Munish has
Dr.
joined.
Vikrant.
Pooja has joined. Yeah.
Yeah.
I think
So,
welcome
you all. Welcome you all, Dr. Arpan, Dr. Pandit, Dr. Pooja, and Dr. Munish. So we will first go through the extracorporeal therapies presentation by Dr. Vikrant, who made some overview of the last 3-4 years, the most maybe milestone research work. Then probably we'll take the question. Over to you, Dr. Vikrant.
Thank you, sir. I hope I'm audible.
Yes.
Yeah. So good evening, all the esteemed faculty and my colleagues and friends. So let's start with extracorporeal therapies. As you all know, the extracorporeal therapies include, it's an umbrella term, and it includes extracorporeal blood purification techniques and extracorporeal life support system, which includes ECMO. So primarily, we are going to focus on ECMO in this discussion, and we are going to go through ECMO CS trial, ECLS shock trial, hemoglobin targets in ECMO with the PROTECMO study. Then we are going to go through ELSO recommendations on neuromonitoring, which were published in 2024. And then we are going to discuss ECOR ESICM guidelines, Vent Avoid trial, and ECPR, a meta-analysis and an inception trial. So coming to ECMO CS trial published in Circulation, it was a randomized control trial where 122 patients were randomized, and 58 were randomized to VA ECMO, immediate VA ECMO group, and 59 to no immediate VA ECMO group. VA ECMO group, out of the VA, no immediate VA ECMO group, 23 patients, that is 39% of the patients, ultimately required VA ECMO. And the 30-day incidence of the resuscitated cardiac arrest, all-cause mortality, serious adverse events, sepsis, pneumonia, stroke, leg ischemia, and bleeding was not statistically significant in both the groups. So the strength of this study was that it was one of those rare studies which completed the randomization, especially with respect to the VA ECMO background. I'm sorry. It was a well-made study, web-based randomization and a pragmatic study, and multiple centers were involved in this study. Now, the weaknesses were that some of the patients were already on a high support at the time of randomization, so arguably it could not be considered as early VA ECMO.
and the goals of the ECMO initiation were not clearly defined. And a high level of crossover was there, like 39% as we discussed, which ultimately required VECMO. The conclusion was that immediate implementation of VECMO in patients with rapidly deteriorating or severe cardiogenic shock did with an early conservative strategy that permitted downstream use of VECMO in case of worsening hemodynamic status. Similar study, which was the ECLS shock trial, where the patient pool was more specified in a group. The cause of the cardiogenic shock was infarct related. So, a well-conducted randomized trial. It was conducted in 2 countries, Germany and Slovenia, and nearly 420 patients were randomized in this, and 417 were included. So it included acute MI patients complicated by cardiogenic shock and planned early revascularization either by PCI or by CABG were included in this study. They defined cardiogenic shock as systolic blood pressure less than 90 for more than 30 minutes, or the initiation of catecholamines to maintain a SBP of more than 90, an arterial lactate level of more than 3, and signs of impaired organ perfusion with at least one criteria like altered mental status or cold, clammy skin, or urine output less than 30 ml per hour. So the primary outcome here was again death due to any cause. And at 30 days, the incidence was similar in both the groups, 47% versus 49%. And it concluded that early unselected VA-ECMO in acute MI complicated by cardiogenic shock will not reduce mortality, rather may increase complications. Now the complications were primarily bleeding related here.
So we will just wait here, Dr. Vikrant.
Yeah. Yes, sure.
Because we are going to a different topic. So just to take the discussion forward, the ECMO CS trial, which was there published in 2022, was a very, as you said, a very rare kind of studies to actually doing a randomization in that emergency situation, which will be a challenge. I'm not expecting such trials also in the future to be coming with a randomization, and a difficult task to actually prove the mortality benefit in them. Dr. Arpan, just to take you there, there was a discussion related to timing, and controversially, the timing was talking about early or a stabilization with a vasopressor trial. If it is not helping and the patient is further deteriorating, there was a crossover of 39%. So what will be a take on timing? Dr. Arpan,
Thank
can
you.
you hear us?
Yeah. Can you hear me?
Yeah, sir. Please go ahead.
Okay. So this is a one of the hurriedly done trial for probably just to establish how the VA-ECMO works or not work in cardiogenic shock. And if you see, the inclusion criteria is very much specific, that those are the hemodynamic criteria basically for if the cardiac index is less than 2.2 or with some amount of vasopressors, the 0.1 noradrenaline, or the blood pressure is not going up, your CVP is high. So they have a very particular criteria, and where actually the patient is, if you see, the patients are in the SKY classification D. So already
So just before you go into the further discussion, both these trials, ECMO CS trial or ECMO ECLS shock trial, both were before this SKY classification. So they have not been defined in hemometabolic syndrome, but they were talking about, as you said, other different parameters like cold, clammy extremities, low perfusion state, or as you said, cardiac index, or somewhere combination of hemodynamic or macrodynamic parameters. So it is all pre-SKY era. That's what was the concern. And they took a good long time. If I'm not wrong, it was a 6 years trial between 2014 to some 18 or 20 is the time taken. Yeah, please go ahead, sir.
Yeah, so that's I'm telling you. So this is a kind of trial, which is number one, the randomization is based on very much a kind of individual choice of these things. Whether the patient's periphery is cold, your blood pressure is not coming up with the vasopressors. So frankly speaking, it's very difficult to randomize this kind of patients. That's why that much of crossover happened when in the other group, when these patients dip into this kind of criteria, they had to cross over for 23 patients, like almost 39% of crossover. So if you remember, the Eolia has a good amount of crossover also. The trial was a failure, but the crossover make this trial very much important. That means that VA ECMO in early shock or whatever the patients, until unless you patients are stabilized with vasopressors or volume or whatever maybe your conservative treatment, you should not offer VA ECMO in this group. That is our classical textbook teaching, and the results happened as we have thought. The early VA ECMO has surpassed its side effects rather than the good effects of VA ECMO in this kind of patients. So that has happened. And second one is the VA ECMO or any kind of ECMO is a supportive therapy. So we don't know what are the patients they have given. They have not written the exit strategies, or whenever they have talked about the second support, whatever has been started after VA ECMO within 30 days, they have stopped them recruiting. So this is another thing, because sometimes the long VA ECMO patients, more than 14 days, we had to go on venting the heart or kind of putting LVAD or kind of a transplant. So they have actually excluded those patients. So as a supportive therapy, if you don't utter those words for definitive therapy like angioplasties, what you have done for what transplants, what actually that has taken as a failure, that has taken as an exclusion criteria rather than inclusion criteria, as VA ECMO successfully targeted those exit strategies. So these exit strategies are not very much well defined in this kind of trials, and that's why the outcome is very much abysmal, what we are getting here.
So just to again summarize, sir, if I have a patient who is in cardiogenic shock, what will be my timing?
So the timing should be, you should see where he is. He is in, as the sky has came, it is very easier to put him either as a class C or class D, wherever you are. If you are in, it's a dipping patient, or patient is cold, clammy, and patient is not passing urine and lactate is high, obviously the VA ECMO is it will come as a regular choice over and above your conservative strategies. But the patients, you have to keep in mind that whenever you are putting the patients on venoarterial ECMO, you have to think of your exit strategy also. Like a patient who is having a 20% ejection fraction, coming with a cardiogenic shock, you are sure that these patients, the VA ECMO will rescue them, but you don't know whether you can there is an exit strategy or not. So always a VA ECMO should be associated with an exit strategy, like an angioplasty. If it is an MI, angioplasty is required, or a venting strategy, or a kind of your destination therapy is required or not. That is my take on this.
I think very well summarized. Now with the existing SKY classification, C and D category maybe qualifies for considering a VA ECMO. Second point he made is look at the trajectory. After your all efforts, if the patient is dipping, that's the time where you need to think about it. Third point he made is what are you going to do? Is it for bridging to recovery in a myocarditis, bridging to a angioplasty, bridging to a ongoing failure? If on a timeline you're listing them for a transplant or a LVAD support for a long term, so that need to be also defined on the process. That's what he made, and that will give you the outcome, not just putting a patient on a ECMO. And he spoke very well about this. This is such an hurriedly done study. where the randomization timing early, and then they said give a trial of vasopressus, and then going for those crossover of a 39%, almost half of them, 40% of them has done. So just to actually add continuation of his discussion, he spoke about there is no clarity on what kind of these patients are in cardiogenic shock, whether they are on acute coronary syndromes, they are myocarditis patient, or a heart failure patient. The second study spoke about it. The ECLS shock trial is predominantly talking about the patients who have been revascularized. And whenever they came about this revascularized patient, when they are in cardiogenic shock with a definition, when they attempted a kind of ECMO in them versus a standard care, they could not find any difference. So to answer that, we'll take Dr. Pooja on board. Can we have Dr. Pooja ma'am on board? So ma'am, why if we were talking about the ECMO, VA ECMO helps in these patients, in this ECLS shock trial, why we didn't get any benefit? Is that we had not been categorized which kind of cardiogenic shock patient required? We know the etiology, which was actually pointed out by Dr. Arpan in the previous trial, but here we know only a cohort who had actually needed a revascularization has been taken, but still we didn't see any difference. What do you think is the reason?
So, as rightly said by Dr. Arpan Chakravarti, sir.
No. Come.
Am I audible?
Yeah, ma'am, please go ahead.
Yeah. So, as he has rightly said, that the trial was very hurriedly done, plus it was stopped very prematurely. They did not have any defined subsets where they have used it. Now, when they used it in these in the cardiogenic shock, they were not able to get the results which they were expecting. They were trying to show a mortality benefit, which they couldn't. So the complications rate.
Ma'am, just to be specific on the question, that was what happened in ECMO CS trial.
Yes.
But later on, when it came to ECLS shock trial, the etiology was the uniformly same, infarct-related cardiogenic shock, where they attempted a revascularization. In this trial,
am I audible?
Also, yeah, ma'am. Can you hear me, ma'am?
Your voice.
Hello, Dr. Pooja, can you hear me?
So I am not able to hear clearly. Am I clear?
Yeah, you are clear, but are you able to hear my voice?
Let me rejoin.
Okay. So, Dr. Arpan, you can continue. Then we will also take Dr. Pooja. So, in this trial, ECLS shock trial, this is a very specific cohort. So, what is your take on this? Dr. Arpan, can you hear me? Arindam sir, can you hear me?
Yes. Please tell me, Venkat, one more time.
Yeah, I just wanted Dr. Arpan Chakravarti sir to
Arpan
actually
is
answer.
here, I think.
Dr. Arpan, can you hear me?
I think Venkat, Dr. Pandit is also on board.
Yeah,
He was
yeah.
traveling, but he has joined.
Hi, Venkat
Pandit.
bhai, how are you?
Yeah. Hi, good evening, sir. Nice
Good evening.
again having in a academic session. Sir, these are the two trials which we are talking about. The previous ECMO CS trial, which we already discussed with Dr. Arpan, saying in a different category. But the second one, ECLS shock trial, which is done in a very specific cohort of infarct-related cardiogenic shock, where there was an attempt of using ECMO in this shock patient.
Yeah.
Again, in this particular cohort, also they could not actually find any major difference. What do you think is the reason in this trial? Also, is the non-specifically they attempted in all patients? That's the reason, or you think the patients' ECMO-related complication always also counterbalance the benefit?
I think two things are there, and both the points you've made, Venkat bhai. So the first thing is, when you choose a patient for ECMO, you cannot generalize that all patients who come in with an infarct, I'm going to put them onto a ECMO. So the patients who will benefit need to be thought about very clearly. Somebody who has a stunned myocardium versus somebody who has a completely ischemic heart, which a myocardium which is not viable, will obviously not do even on ECMO. And the second is, whenever we do ECMO in these patients who have acute coronary syndrome of any type, there is a mixture of anticoagulation used with traditional anticoagulants as well as with dual antiplatelet agents, and the ECMO complications obviously are very, very bad. So I believe that these two are the reasons why we could not get a positive outcome in both the trials. So the second trial was, of course, the question which you have asked, where the patients who had infarcted, where still we could not get a positive outcome out of them. And this is my take on it, unless there is something else which they have not revealed in the trial. But I had read the trial a few weeks ago, and these were the two things which I could think of.
Yeah. So, Dr. Pujak, are you here? Can you hear us? I think Dr. Pooja lost the connection. I think you made the two same points, sir, that you cannot actually have a generalized statement. You cannot have an unselected way saying that one group will get an ECMO when there is a cardiogenic shock. You need, again, I was just mentioning just before this discussion that these both trials were done prior to SKY classification, which came. So they were all talking about systolic blood pressure alone as a macrodynamics. The other factors were not taken into account. So Dr. Vikrant will take on to the presentation, and then probably will take the questions after this neuroprognostication.
Yeah, yes, sir. So coming to the ELSO 2024 recommendations on neurological monitoring and management in adult ECMO patients. So ELSO described that amongst the acute brain injury, hypoxic ischemic brain injury and ischemic stroke are the most common, have the most common incidences, and nearly 16% patients have acute brain injury in all the ECMO patients seen worldwide. So coming to the neuromonitoring and neuroimaging recommendations, so most of the recommendations are pretty standard, which are practiced worldwide, like performing neurological consultation if there is acute neurological change, assessing pupils, using pupillometry wherever available. But one important recommendation was to monitor continuous cerebral regional oxygen saturation, especially in VA ECMO. So that was one important recommendation. And going ahead with the bedside management, other than avoiding hypoxemia, hyperoxemia, maintaining mean arterial pressure more than 70, one important recommendation was to continuously monitor core temperature and considering mild to moderate hypothermia, that is 33 to 36 degree temperature, Celsius temperature, for 24 to 48 hours in VA ECMO, especially in eCPR, and it is not recommended in VV ECMO. In the interventional neurology, neurosurgery, and neurocritical care segment, they strictly recommended against TPA in acute ischemic stroke due to high risk of bleeding. Mechanical thrombectomy, if a large vessel occlusion is there, can be considered. If the decompressive craniectomy has been suggested, there should be a thorough discussion about risk benefit, amongst the stakeholders, the caregivers, and the family members about the possibilities. And they have suggested that extraventricular drain can be considered if there is a high risk of death due to intraventricular hemorrhage or hydrocephalus. Then, in spite of doing all the appropriate interventions, if the patient's condition unfortunately deteriorates neurologically, then they have set some specific recommendations for neuroprognostication. It should be multidisciplinary and a multimodal approach, including neuroexamination and electrophysiological studies and neuroimaging. There should not be a single factor like brain imaging to be the sole determinant of neuroprognostication. In case of brain death determination, they have advised to exclude confounding factor and consider guidelines and also the specific laws of that particular country. And if apnea test is found to be challenging, then cerebral angiogram or nuclear scan can be used as an ancillary test. There should be frequent meeting between the caregivers and the family members, and thorough counseling of the family members in case of neuroprognostication has to be done, and declaration of brain death is to be done. So they have set some criteria of how to perform apnea testing. Over to you, sir, Dr. Venkat, about
Yeah,
discussion
so
on
just to
neuroprognostication.
take the continuity of the further discussion of this guidances in neuroprognostication and neuromonitoring, we'll take question of Dr. Munish. Can we have Dr. Munish on board? Dr. Munish?
Yeah, sir. Hi.
Hi, Dr. Munish. Just to take this discussion of neuromonitoring and neuroprognostication, there were some guidances related to, again, mild to moderate hypothermia, which we have seen with TTM in the earlier time. So what will be your take on this during a patient on a VA ECMO? I think the whole discussion when I gone through this guidances felt like most of these ECMOs happen in either severe hypoxemic situations where you put an emergent way, or after a post CPR when there is an eCPR happening and you put. Or some of these patients also go through a chronic period of turbulences in both hemodynamically and oxygenation wise. So in that reason, I think there's multiple guidances of both the neuromonitoring and prognostications are given. But more specifically, I wanted to learn from you related to the guidance of hypothermia, the mild to moderate hypothermia in a VA ECMO in this.
Well, sir, as you rightly said, now the issue with the VECMO is that many a times we are placing either pre-ECMO, we are facing turbulence as related to the ischemic time of the brain, and sometimes post initiation also we have the symptoms like Harlequin syndrome, and even the lungs going bad. So both of these situations can warrant special neuroprotection. That's why they recommend continuous monitoring of oximetry also post immunization. But a lot of data and the study has been based on non-ECMO patients, the TTM trials that you said. It's an extrapolation of the data, and the basis is that only. Personally speaking, definitely hypothermia or the temperature going above is strict no. That's a definite negative from my end. But yeah, going on the other extreme also, I'm not that comfortable. I'm okay with the 36-ish temperature, because that's the benefit, and whatever has
Absolutely.
been is at 36 also. Vis-a-vis the bleeding, well, can't say that can pinpoint that the bleeding risk increases because of hypothermia itself, not because of other reasons. But your temperature maintenance of this, and not only for VV also, though it's not for neuroprotection, but we also decrease the temperature for decreasing the oxygen demand. So I think a 36 odd temperature shouldn't be a problem in such cases.
Yeah, Dr. Manish, I completely echo with you, saying ki nowadays, irrespective of whether they are post hypoxic arrest or they are on ECMO for some other concerns, we try to avoid fever, and it is very easy. In fact, when you have already on
Exactly.
ECMO, because you don't never get a fever in them. So most of the times, if you have a thermoregulatory ad hoc and additional system, most of your ECMOs have add-on, so your temperature is regulated. You can actually choose what amount of temperature you want. So
Correct.
the no fever is the rule, and that is very easily achievable. So we all are little skeptical about keeping the temperature maybe 33, which is 33 to 36 degrees, because we all came out of it in recent times in hypoxic ischemic injury times. We were talking about those
Exactly.
temperature in the last decade, but slowly now after the recent trials, we are slowly coming out of. So no fever is the general idea, and maybe a borderline mild hypothermia, but not that maybe moderate, that is 33 degree. I agree with you. And any lights on the other neuromonitoring, as you pointed out, most of these patients, when they are not in full normal consciousness or normal sensorium, about those regional oxygen monitoring systems and all that. What do your take on that?
I think they are helpful. Like traditional teaching, obviously, is that a conscious patient is the best test of sensorium, but that's not always the ideal scenario in the world. But yeah, cerebral oximetry, we routinely use it, and I think in the scenario of a limited monitoring and testing that can be done on VECMO, it's not a bad idea to have a cerebral oximetry on flow. At least it gives you an idea, even if it's not diagnostic, but it's a indicator that okay, something might be amiss. You can maybe go on to other ancillary tests. But yeah, and it's not that expensive, and easily, non-invasively we can place. I am totally up for it.
So any patient whose sensorium is suboptimal after probably giving a trial of discontinuation of sedation,
Correct.
these other allied after your standard clinical examination like pupillometry or a pupil and your regular assessment of clinical examination, if you are not getting a chance, then electrical studies like EEG, somatosensory evok potential, oximetries may be useful. And then if that's not working, I think there is an guidance for imaging also.
Exactly.
Dr.
They are
Arpan, are you
more
around?
of supportive and a continuous test rather than a static test.
Yeah.
So definitely.
Dr. Arpan, are you around? So there are questions related to anticoagulation in acute ischemic stroke. So we have seen some of these patients who actually had an acute ischemic stroke. So Dr. Rahul, Dr. Pandit, are you around?
Yes, I am very much here.
So Pandit sir, there are questions related to acute ischemic stroke patients. Post thrombectomy, they are already on ECMO, VECMO or
Yeah.
AV-ECMO. So how do you anticoagulate them, because they carry a risk of rebleed into the intracranial cavities? So how do you what is your take on the anticoagulating them?
So there are two scenarios here. First is the scenario which you mentioned, that there is acute ischemic stroke. How do you anticoagulate them? Second is, which is a very rare one, where you actually have a stroke when you are on ECMO already. So that these are the two different ones, and where what you want to do is going to be different. I think if you have a acute ischemic stroke and you want to anticoagulate these patients, I would keep these patients on minimum heparin still. That is the best anticoagulation which I think we can use. And if there is an option of actually doing a ACT at the lower level and keeping it around 120 to 140 and allowing the ECMO to run on that, that's the best option which we would think of. If a person has a stroke while the patient is already on ECMO, then obviously TPA becomes a problem. So in that case, if there is a capability of a center to do a mechanical thrombectomy, that can obviously be offered. I think these are very academic things. In a reality, we rarely would do any of this. In most of the times, if I have a big stroke in a patient who comes in with either acute stroke or has a stroke on ECMO, more often than not, the neuroprognostication would be very, very poor either ways. And we would not be pushing hard for doing any of these interventions. That's the ground-based reality. Well, theoretically, you can do everything. Giving the antidote, and then you thrombolize them. There are studies about that as well. On non-ECMO patients, I'm talking about. You always find doing odd things, but no trial can justify this kind of a thing, because one, it's very rare, and doing a trial is not going to be possible. So you are going to basically take it case by case, and that's how the anticoagulation will be. But for me, if I have to anticoagulate anybody, I will use the anticoagulation which I know I've used for hundreds of years and which I can reverse quickly if required. These are the two determinants of my anticoagulation.
So exactly, sir. If a patient on ECMO gets a ischemic stroke, there is no thrombolytic, that's no TPA. And if available, mechanical thrombectomy should be the guide. And you rightly pointed out the post anticoagulation in them, either you should be on the lower range, not to actually make giving the anticoagulation as we generally expect of around 160 to 180. So we do, all of us practice in the same way. And if we also believe it's to be a very higher risk, then sometimes, because the circuits, most of the circuits are very well coated with heparin, we also wait for 24 hours without any heparin and monitoring the ACT levels in them.
Absolutely.
So, yeah, so Dr. Pooja joined. Ma'am, can you just elaborate on this neuroprognostic monitoring systems, your thoughts on that?
So, yeah, sorry, my net was down. So, I think, as Dr. Rahul Pandit has already very beautifully outlined, that anticoagulation has to be done in patients who should not be done in patients who are undergoing, who have a large ischemic stroke. They should instead have some mechanical thrombectomy, although most of the neurologists will not agree to it. But in some cases, in our hospital as well, we do heparin-free VV ECMOs. But in VA ECMOs, it sometimes becomes a bit difficult because they carry a high risk for thromboembolism as well. So we can briefly sedate in the heparin or any other anticoagulation which we are using, and see if they are at high risk for hemorrhage, like if they have a large infarct, or if the risk, assess the risk and benefit ratio in case of as of the case to case basis, and repeat the neuroimaging as well, especially with the bedside CT, if it is
So,
possible.
yeah, so the common consensus is that use thrombectomy and probably the anticoagulations limit yourself. So the
Venkat
other
bhai,
question, ma'am.
can I add a
Yeah,
few
yeah,
things
please.
on
Yeah,
neuroprognostication? Is it okay?
yeah. Yes, yes, sir,
So,
please.
So,
okay, sorry.
so
Yeah.
neuroprognostication is completely, it's not difficult at all. Most of the evidence is extrapolated from
Anesthesia rooms and
hypoxic brain injury and traumatic brain injury. So if you look at students who are there on the program right now, you have to basically avoid secondary injury. So all the H's, hyponatremia, hyperthermia, uh, your hypoglycemia,
hypotension,
hypoxemia,
hypoxia, hypoglycemia.
hypertension. You look at all the H's and you avoid all the H's. And you should basically try and keep the normal physiology as much as you can. And then when you prognosticate a patient, obviously you should give a good sedation-free time to do a good neuroprognostication. If sedation cannot be stopped, then a daily pupillometer change, pupillometer check, at least every 2 hourly should be done at the bedside. Any change in the pupillary side should be looked at. Brain oximetry is absolutely a doable thing, and I believe for the first 2 to 3 days, if you employ that as a strategy to actually guide, it is not a bad thing to do. But ultimately, EEG and somatosensor evoke potential. By the time you start thinking of that, the damage is done. So you need to actually step in before that. You got to be very, very clear about your neuro prognostication. If the pupils are not reacting, if they are basically sufficiently reacting, you need to start thinking what the problem is. Yeah, EEG and SSEP will give you two different things. EEG will tell you whether it's a non-convulsive state or not, or whether there's any brain activity or not. SSEP will actually help you into prognosticating whether this patient is going to wake up or not. But your N values, the N17, N20 values are not very sensitive for prognosticating in this group of patients because they have not been studied. So I think SSEP also should be taken up with a pinch of salt when you're looking at prognosticating patients. If you look at the trials, and Vikrant shared with me one trial, 13 patients का trial है sir. 13 patients के ऊपर क्या हम लोग सोचेंगे कि SSEP को use करने का कि नहीं. So I think we need to take all of these things with a bit of pinch of salt.
But
Ultimately,
Rahul
CT
sir,
scan will show you things.
yeah, Rahul sir, but there is a good thing happened after this guidance that we are looking at the neuroprognostication, neuromonitoring as a tool because most of our patients will be sedated and paralyzed. Some of them will have already, as you said, primary injury, secondary injury. So if their sensorium was suboptimal, thinking about their neuroprognostication is at least a guidance here. You may use a different tool, but there is a guidance here. And right
100%.
now, most of our practices is if in a couple of days the patient gets synced, we try to kick them awake. Awake ECMOs if they move forward. If they tolerate well, we even extubate in some of the situations if possible. And that's a way forward. But this is a guidance where we all are talking about a neuroprognostication or a neuromonitoring. So taking it forward, Vikrant will go to the next session. and then from there we'll take questions.
Thank you, sir. So, also in their last recommendations on transfusion in 2021, they had advised to keep hemoglobin between 7 to 9, with a higher goal for neonates and children, and for adults, lower goal, stable patients relatively. So, coming to our next study, PROTECMO study, which had a aim to narrow down the targets, hemoglobin targets in ECMO patients. So it was a multi-center observational study, but it was done in 41 centers over multiple countries in Europe, North America, Asia, and Australia. Adult patients with acute respiratory distress syndrome (ARDS) who were on VV ECMO were included in this study, and it included 604 patients. So the mean hemoglobin concentration in patients while undergoing cannulation was 10.9. What it found was the PRBC transfusion was associated with lower risk of death only when transfused for a hemoglobin concentration less than 7. And there was no significant effect in reducing mortality when the hemoglobin range was between 7 to 7.9, 8 to 9.9, or more than 10. So over to you, sir.
Yeah, Dr. Munish, can you just talk about how do you practice? What is your practice? What is your target hemoglobin? These cutoffs of 7 and 10, we all understand in most of our intensive care patients, we don't consider transfusing above 10, and we probably will transfuse any patient whose hemoglobin is below 7. And this all debates come between the 7 to 10 or 7 to 9. And in ECMO patients, what will be your probably practice?
Well, so frankly speaking, non-ECMO patients, we always have been using this target of 7. And we also know that the more you transfuse, the risk of immunosuppression, passage of infection, and trial all does add on. I'll be very frank, 7 a bit tight on me. We generally have been practicing the ELSO guideline and all, and we the earlier one, and keep it around 9 or 8, 9, both for V and VV. Oxygen carrying capacity is one thing that we do monitor. We calculate it at least once a day. And hemoglobin, as you all know, is one of the parameters for the oxygen carrying capacity part. 7 will take some time to adopt going so low, but 8-ish, 9-ish, I'll be a bit comfortable. I understand this thing, though the level of evidence is okay-ish in this, and I would love to cut down the transfusions, but that's my honest thought here.
Yeah, Dr. Manish, you rightly pointed out it's not just a number, a hemoglobin number, but you also take in a lot of context, including, as you said, oxygen carrying capacity. What is the final oxygen delivered to this patient, and what is your hemodynamics? Do you want some amount of more RBCs to carry them? So if my patient is rock solid stable with a 7, no problem at all. My lactates are normal, my metabolites all are fine. So probably I may okay with 7, but there are many situations, as you rightly pointed out, in these patients where we probably keep on trying to match that 9 or 10 in many occasions. And those are the times where there are many other issues come up, just not a patient on ECMO, but other challenges. Any comments on that from any other panelists who are there? Dr. Pooja?
No,
So
Dr.
I am of the same opinion that 7 is a bit tight for me as well. So we try to maintain it around 9-ish, so that because the newer recommendation will, as rightly pointed out, it will take some time to sink in. We are more, because we have been practicing the 9 value for a long time now. It's judging on the patient's capacity and clinical condition. If he's a heart patient, so even if he's a CAD patient, we're not very comfortable in keeping it him at 7 to 8.
Dr. Arpan, are you there?
Yes.
Rahul, sir. Yeah, Dr. Arpan, what is your comment of this newer additional guidances?
This I have presented in last walk also, the transfusion practices. If you see, when you put ECMO for initial 48 hours, when there is a volume requirement in the circuit and these things, we try to keep a higher hematocrit goal. We try to keep
Yes.
around, if it is more, it is fine. But in the long run, probably after 48 to 72 hours, when things got stabilized, it is a regular ECMO run, you are attempting for another 2 weeks or probably 3 weeks of ECMO run, then the hemoglobin, acceptance of hemoglobin is coming down to 7, maybe lower than 7 also. If the patient is doing otherwise fine, there is no rise in lactate or any kind of hypotension, or he was not using vasopressors too much. So a kind of dynamic acceptance of the hemoglobin goal is important. And obviously, if you reduce the transfusion, it's a directly proportional to your ECMO outcome. The infection is going to go down, and things are better when you look at the long run. But for initial 24 to 48 hours, probably initial 72 hours, particularly in veno-arterial ECMO, where there is a chance of bleeding, the circuit requirement is there, the volume requirement is there. At that point of time, you should maintain a hemoglobin of around 9 to 10 for patients for a comfortable ECMO run.
Yeah, thank you. So Vikrant will go to the next
Yeah.
two final things, please.
Yeah. So coming to eCPR, so there is a meta-analysis published recently in 2024 about eCPR in cardiac arrest, which included both out-of-hospital cardiac arrest and in-hospital cardiac arrest. So it basically studied 13 studies between 2000 to 2023, and the primary outcome was in-hospital mortality. And it concluded that there was a significant reduction in mortality, even in OHCA group, if eCPR was provided over conventional CPR. But if we come to Inception trial, which was done recently, its results were as surprising as the Inception movie because it concluded that the extracorporeal CPR and conventional CPR had similar effect on the survival. So there are two more studies before Inception studies to mention, the ARREST trial and the Prague study. No, they both had showed benefit of eCPR, but the advantages they had were they were done in single center, so there was a lot of protocolized systematic approach to each case, and the low flow time was lesser. Whereas in Inception trial, the time to ECMO was 74 minutes. Over to you, sir, about eCPR.
So, Dr. Arpan, what will be the maximum low flow time you will accept for initiation of eCPR if you find an ideal patient with reversible cause?
See, for me, it is less than 45 minutes. Okay, all of us has done some amount of eCPR. Probably the numbers are not great, probably, but we have seen that if it crosses more than an hour, it is not giving a good results, and that is probably shown in Inception, where you, in comparison to what your Prague OHCA or the ARREST has outperformed the Inception. So yeah, as early as you can put the patients on ECMO with an refractory cardiac arrest, it is better. So low flow time should be less than 45 minutes. If not possible, it should be less than an hour to get a good neurological outcome and obviously the good overall outcome.
So, Dr. Munish, what are the challenges do you think we are facing right now? As Dr. Arpan said, many of us have done occasionally 1 or 2 cases here and there whenever there is a possibility and situation arrived. But the numbers are still in a very countable way. We have done around 5 or 6. Dr. Arpan was talking to me, gathering this information so that we can collate that eCPR data, which he is doing right now. But what do you think your challenge, Dr. Munish?
Well, sir, frankly speaking, the Indian scenario is totally different from the European, the Western scenario. Many of the ECPRs that I have done are cases where we were preparing for ECMO, already the consent was in place and the financials had been taken care of, or within the 9 to 6 period when all the stakeholders are in place. The true sense of CCPR is, a very far-fetched thing in our country, out of hospital or even in hospital, because during the off periods, not everyone would be available. Financial, I think, is the biggest setback because out west it's state sponsored. You don't have to think about, taking a consent or getting a financial clearance. And whereas ECPR mostly in our country is done in corporate hospitals where you need to get a justification where this 3.2 lakh or 2.5 lakh or circuit is being charged. Apart from that, awareness not only amongst the physicians but the general population, because you already know that the emotion might run when you are not able to save a patient and do all the cannulations and uh, also open an expensive circuit and you are not able to go on flows. So a lot of these challenges are there. Yes, we have done many of them in which we are already in discussion uh, with this. But I think these are two major challenges that we'll face in our country.
Okay, thank you. Dr. Vikrant will take that last trial and then we'll go to the please.
Venkat, I think ECPR.
So we will come to you, sir. Anyway, you will have the final comments to hear after this trial.
Okay.
So coming to the last topic, that is ECOR, extracorporeal CO2 removal. So there was a vent-avoid trial which was done on ECOR. It basically was studied on COPD patients having exacerbation. So this trial was stopped early, and early because they were finding it difficult to find patients for recruiting. So 113 patients out of 180 were recruited, and the ECOR arm, had a significantly higher mortality. So they concluded that even in exacerbation of COPD, the use of ECOR, did not improve the ventilator-free days and rather led to higher mortality. Even ESICM guidelines 2023 on ARDS, they have recommended against strong recommendations there against the ECOR. So over to you, sir, about ECOR.
Yeah, Dr. Pooja, any comments on this? We were all thinking ECOR can be a solution for isolated hypercarbic states without much
Yes,
of
everyone
hypoxia.
was thinking like that only. But unfortunately, the ECOR-VENT trial, it was done to determine whether it will increase the number of ventilatory-free days within the first 5 days in COPD patients with acute exacerbation, especially who had failed NIV or who were having weaning failure to wean problems with them. So, but at the end of the trial, they concluded that the ventilatory free days were not increased after the use of ECOR. Instead, the complications were increasing. So that is why it has gone out of favor. And now even the guideline says that it should not be used.
So yeah, I understand in the guidelines they are talking about ARDS, but in the trial it is about COPD, CO2 narcosis, if I'm not wrong. And probably in all ARDS patients, when you have a CO2 removal issue, then you also will have some amount of hypoxemic issue. So in ARDS, yes, most of us don't probably selectively try to remove CO2 alone because we do see them to also have a very bad hypoxia. But our already existing thinking process was it is about reactive airway with COPD
वो
or
ट्रेन नहीं
asthma.
चालू करूं ये वाली
So that was the. So over to you, Dr. Rahul Pandit, for summarizing this so that we can take a final comments and conclude. Over to you, Dr. Rahul.
Thank you, Dr. Venkat. And what a lovely session this has been. So if I was to summarize all the papers which we discussed, I believe the ECMO cardiogenic shock and the ECLS shock, we discussed that we should be looking at individualizing the patients before being put up on ECMO who come in with cardiogenic shock, especially patients who have a acute infarct. Just because they have an infarct, we should not be putting all of them onto a cardiogenic shock. A refractory cardiogenic shock will possibly some of them will benefit, but the patient has to be individually chosen. You rightly pointed out that there is a good trend now towards neuro monitoring, and into 2020 for 22, 24, I believe neuro monitoring is something which we should be looking objectively, pupillometer, looking at the oxygen saturations of the brain, looking at doing somatosensory evoked potential if there is a poor outcome which is thought of, or a EEG to begin with. I believe all of these things have to be deployed. I just wanted to add up on the brain death thing, which we
Yes,
sort of
is
quite
there
close to my heart.
declaration of
All
brain
the
death?
time we talk about brain death in normal patients who are not on ECMO. ECMO patients present their own challenge, and the law of the land currently is that ancillary tests are not a part of the Doha Act currently. So ideal thing would be to do an ancillary CT angio or a 4-vessel DSA and prove that they are brain dead. That's the easiest thing and the most sure shot thing, because you've taken out all the risk of having an apnea test and the challenges of doing an apnea test in these patients. But I would still say that if you really have to do an apnea test, then you'll have to put down your fresh gas flow and you'll have to think of doing an apnea test that way. But it would never be perfect, because you will never have a good window where your hypercarbia would actually come up very quickly, and you'll be able to say for sure that this patient is brain dead and not breathing well. So I think the ancillary test has to be taken up as a exceptional thing in this, and there are exceptions in the country where we use ancillary tests while we are declaring this patient brain dead. I think anticoagulation was easy. We all agreed that heparin should be the choice, which is what we have used for a long time. And these scenarios, while they are theoretically good to discuss, practically, probably most of us would not face it. And if there is an IC bleed or if there is a problem with anticoagulating them for a short period of time, 24 to 48 hours, you may think of going without heparin, because these circuits are anyways primed with heparin as well. I believe hemoglobin target again is very simple. You should tolerate a hemoglobin which is a little higher, but Arpan rightly pointed out that you can, as the ECMO becomes more settled, you may perhaps go down to a target which could be possibly down to 7. Below 7, I don't know. And that's because we know that generally in critical ill patients, the blood transfusions do have a tendency to increase the morbidity as well as mortality and the hospital cost. So I think that's something which we should be doing very clearly. eCPR, I wanted to give one comment that if it's out of hospital cardiac arrest and we don't know the time outside, then I think 20 to 25 minutes is what we should be looking at, really making a decision whether this patient needs to be put on ECMO or not, because there is an unspecified period of hypotension and arrest unless you have a very clear history. In hospital cardiac arrest, completely agree. 45 minutes of good CPR, you should definitely still put this patient on ECMO. The important thing is to make a call of ECMO at 10 minutes of cardiac arrest, which is not responding. If you have not made a call of ECMO at 10 minutes, trust me, you are in hospital like ours, where we generally feel that we will not encounter a lot of problems with the billings and stuff. We are not able to assemble the whole team, put in an ECMO within the 25-30 minutes time following that. So that means that you have to make a call between 10 to 15 minutes of it. And again, ECOR, I think, I believe it's going to die slowly. I don't think it's going to actually have a lot of takers. One-off patient, we will be doing ECOR still, and we would discuss about it. So that's my
thank
take
you.
and my summary.
Very,
Over to you, Dr. Venkat.
wonderfully summarized, sir. Thank you very much. Thank you, Arpan sir. Thank you, Pooja ma'am and Munish for being here and being a part of this very interesting interaction. Over to you, Arindam sir.
Thank you, Venkat sir.
Venkat, I had been very, very thankful and my heartfelt gratitude for you to join at the last moment. We wanted you for this discussion. Arpan, nice to see you once again. We'll connect somewhere down the line. Dr. Pandit, thank you. Even in your busiest schedule and while traveling, you have joined. Thank you, Munish and Pooja. And I think we have had excellent presentation by Vikrant and supported by Prithima. And we got
Thank
to
you.
know a lot of it. And we hope this is one of the most fastest growing segment of critical care, and everyone takes a very active interest on the extracorporeal therapies. We will come up with some more interesting ideas, concepts, and observations in the next year critical year review. So, thanks once again, and let's
Thank
move to
you.
the.
Best
Thank you,
wishes.
sir. Thank you,
Thank you,
Venkat.
sir.
Thank you, everyone. Venkat bhai, Pooja
Thank you,
madam,
sir.
Arpan
Thank
Thank
you.
bhai,
you.
Thank you,
Thank you,
thank you,
Vikram,
everyone.
Arpan
thank
boss.
you, Arindam, thank you
Thank you.
always for coordinating, and the team for making this happen. I'm sorry I keep on traveling and giving you guys ditch at the last minute, but I could make it this time. I'm happy for myself. Thank you.
Thank you, Rahul sir.
Thank
Thank you. Take care.
Thank you. Bye.
Okay, so last segment would be on critical care imaging, right? And both diagnostic and as well as therapeutic intervention. So here we have Dr. Dhaval Thakkar, who is our senior consultant intervention radiology, who is going to moderate the session. Welcome, Dr. Dhaval. And it would be presented by our consultant, Dr. Ritika Sharma, and supported by our DRNB postdoctoral trainee, Dr. Bijesh Balan, who is going to present the overall overview of whatever happening in critical care imaging and intervention radiology. And for that, we have the experts, Dr. Abhijit Raut, who is the director for uh, uh, clinical radiology and imaging, Reliance Foundation Hospital, senior consultant, and Dr. Rahul Seth. Everyone knows him. He's one of the best known intervention radiologists in the country itself. So, Dr. Sachin Gupta, my friend, who is the secretary elect for ISCCM, and as well as one of the famous intensivist of the country itself. And welcome Dr. Karuna Luthra, who is the director for nuclear medicine, Reliance Foundation Hospital. And also we are from the same college, our college alumnus. So over to you, Dr. Dhaval. And you can take over the session, and then you can also ask
Dr.
Dr.
Arindam,
Ritika and Bijesh to present.
Dr. Arindam, Dr. Rahul Vakharia is also going to join with us. And
Okay, sir.
He is after the neuro part of our imaging.
Yes, sir. He specializes in the neuroimaging.
Yes,
and
yes.
we would be very happy to have Rahul sir also. So
Yeah.
welcome, Dr. Rahul Vakharia.
Thank you for the kind introduction, sir. As we can start.
Dhaval, you are ready, right?
Yes, sir. Yes, sir. Dr.
So
Bijesh,
it's your
start
show
the-
now, henceforth.
Yes.
Hello. Good evening. I hope I'm audible.
Yes, you're
Yes,
audible,
you're
Dr.
audible.
Bijesh.
Yeah. Thank you. I'm privileged enough to present in front of my esteemed panelists, respected seniors, and my colleagues. Our topic will be critical care imaging updates. We'll focus on around 4 to 5 studies which have an impact on critical care. The first one is the DEFIANCE study. So it's the study which is currently recruiting right now. So we are going to focus on the rationale and design for the DEFIANCE study. Here, the deep venous thrombosis is a common medical condition which is associated with clinically significant sequelae, including post-thrombotic syndrome. And currently, anticoagulation remains the guideline recommended treatment for many of these patients with iliofemoral DVT. Even though we have recent technological advances like mechanical thrombectomy for DVT and catheter-guided thrombolysis, a comparison between mechanical thrombectomy with the standard of care anticoagulation there are not much studies regarding that. In the DEFIANCE study, this is an international and actively enrolling RCT in lower extremity DVT, where mechanical thrombectomy with clot retriever system is compared with anticoagulation alone. Approximately 300 patients with unilateral iliofemoral DVT and symptom duration of less than 12 weeks will be randomized, and this study we conduct will include an independent core laboratory for duplex ultrasound assessment, an independent medical monitor for safety abdication, and evaluation of post-thrombotic symptom severity on the Viralta scale. The primary endpoint will be a composite outcome with a occurrence of treatment failure or therapy in the therapy escalation, which will be agitated as by the medical monitor, where the treatment failure will be defined as amputation or gangrene of the target leg or venous thromboembolism related mortality, and the assessment of the post-thrombotic syndrome severity at a 6-month follow-up visit. In addition to this, there will be a component uh, there'll be the severity of the PTS at 6 months will also be validated as a secondary endpoint. Also, the day 10 of the post procedure, the patient will be evaluated with the vessel compressibility on the duplex ultrasound, and the patient-reported pain will be evaluated, and the changes and improvement in edema will be checked. And the safety endpoints will be access site complications requiring endovascular or surgical repair, and the occurrence through the of any major bleeding or a new symptomatic pulmonary embolism. This will be the first RCT to evaluate a mechanical thrombectomy-based interventional approach versus anticoagulation therapy alone for DVT. Over to you, sir.
That's a very good, enriching talk, Dr. Bijesh. If I might have a question for Dr. Rahul Sheth, sir. What would be your guidelines, sir, to intervene in cases of DVT? When would you intervene in cases of DVT?
My intervention in DVT is very clear. One is anything which is above the inguinal ligament where the iliac vein is involved that requires intervention in DVT. Second is if there is severe venous edema which is not responding to anticoagulation therapy at all, and obviously signs and symptoms of going to venous ulceration or venous gangrene which can occur, then I would intervene with DVT. Severely symptomatic for thigh ones when you have the superficial femoral vein is only when there is severe massive edema which is not resolving to anticoagulation therapy. So anything above the inguinal ligament in this day and age, we would rather do a mechanical thrombectomy. And if thrombolysis can be done also with thrombolysis, can be given, that would be ideal for treating symptomatic DVT which is there. Regarding this trial which is being done, they're doing it with a very high-end product called Inari, which is a clot retrieval system. I don't know how many cases they're planning to 300 cases, as you have said. But I think there are much other simpler techniques which can be used, and their comparison should ideally be done in our country with them. This is a Western trial, and they're using a very high-end device, which is pretty expensive. But I think the thing which should be done with is with the standard thrombectomy catheters, which we have, good ones, which are suction thrombectomy catheters, and the role of thrombolysis when it is indicated. That should be the ideal trial which I would like to use on.
Very nicely explained. I think that summarizes the entire point when one should intervene. And sir, if I may ask, what would be your thrombolysis protocol? Would you give bolus thrombolysis or keep an overnight infusion? How would you evaluate, or it's patient?
That depends all on the clinical status of the patient. One, if there is any contraindication to thrombolytic therapy, then definitely we will not use it at all. If it's a complete absolute contraindication, nowadays with the thrombectomy devices which we have, we can achieve a very good clinical result without adding thrombolysis. But if you want to get rid of if there's no contraindication, I would like to give a little bolus, and maybe if maybe an overnight thrombolytic, maybe around 10 to 20 milligrams of Actylize. That's my preferred choice of drug which I use is recombinant tissue plasmonogen activator. And then assess the next day by doing a check venogram. If all open, then stop everything and switch to anticoagulants.
And in that anticoagulation, I assume, would you keep on heparin or Clexane, sir, monitoring?
While I'm doing the procedure, heparin or Clexane, either of the two, preferably heparin, so we can reverse it immediately if there is a bleeding complication. And after that, we can use, if there is no contraindication to any of the newer anticoagulants, if the creatinine is not high or anything of that sort, then we can use the newer anticoagulants like apixaban or rivaroxaban, which is there. Or if not, we can always go with the time-tested warfarin or azithromycin. Only that requires PT-PTT monitoring.
Thank you so much, sir, for summarizing it so well. If I may ask our ICU head, sir, Dr. Arindam, sir, if at all we are not going for mechanical thrombectomy, what would be the ICU protocol for doing intravenous thrombolysis or anticoagulation? How would you treat it for such patients, or the ones we cannot mobilize to the cath lab, or who would have cost issues. Do we have Dr. Arindam, sir? Or anyone from the ICU? Maybe Dr. Ritika, you can take over.
So if definitely, if we are not because due to any reason, if thrombectomy is not possible, then we can do catheter guided thrombolysis, or second is we can go directly to therapeutic anticoagulation.
Okay.
And
Hi, Dr. Dhaval. This is Dr. Sachin. So I'm
Yes.
an intensivist. I would just add, so if, as rightly pointed by Dr. Rahul, that if you're not doing a thrombectomy, right, for whatever reason the patient is not getting mobilized or there's a cost issue, then therapeutic anticoagulation, and this dose is very standard. It is 80 units per kg as a bolus, followed by 18 units per kg per hour as an infusion. That's the standardized dose where you try to keep the APDT, around 50 to 70 seconds. That's the standardized dose that you give for all thrombosis. Now, if you're not doing a thrombolysis, try to understand, if you're not giving an Actylis and RTPA, when it comes to giving an RTPA for a DVT without a PE, so there are no such guidelines. When it comes to PE, you give 100 milligrams over 2 hours, and there are rapid protocols and there are slower protocols which are there. But when it comes to only DVT, RTPA, you don't know the dose. So as a practice, what we do, if I have to give RTPA, as rightly pointed by Dr. Rahul, we generally do a 1/3 dosing. I would not say this is a recommendation. This is a personal preference. When I have to give Actylis, so 35 milligrams is what we give. We give 5 milligram as a bolus and 30 milligrams as a slow infusion over 2 hours. I'm not giving it over night. We are just giving it over 2 hours only for DVT without P.
Okay. Okay. That's a good take on it. And for those cases, do you prefer putting an IVC filter from the opposite side for the clot if the clot is...
Not really. Not really.
Okay. Okay.
So I have one question. If we are going for a thrombectomy, then IVC filter we are putting just to prevent any risk of getting pulmonary thromboembolism. If at all
During the procedure, during the procedure.
Yes, sir.
There is no recommendation for putting an IVC filter for thrombus. There are only very strict guidelines for IVC filter for DVT. But when you have doing a procedure, just to be on the safer side, in case while you're doing the procedure, thrombectomy, you don't want any clot to migrate upwards
Right.
and create an issue, then we put in an IVC filter for safety. So
Yes.
majority of the filters we are putting are retrievable filters. If ever required, they can always remain permanent, but we like to put retrievable filters and retrieve them after 4 to 6 weeks.
Yeah, so that was my question, that when we are going to remove that filter, what is the
So the guidelines are very clear that they say anything between 3 to 6 months. But we can assess the patient clinically after maybe 6 weeks and remove the filter. My preference choice is between 6 to 8 weeks, because the last thing you want is a filter to get sort of stuck in the vein, and then you have to use a lot of techniques to remove it, which can unnecessarily add up to the cost. So between 6 to 8 weeks is what I like to remove, because by 2 months the clot already becomes sort of, if there's a little residual clot also, that becomes chronic, and the risk of pulmonary embolism becomes very low during that time.
Great, great. Thank you so much, Dr. Rahul and Dr. Sachin Gupta and Dr. Ritika for this. I think we can take on the next lecture then, Dr. Ritika.
So next we have the prospective evaluation. Okay. Second. Just a second.
Brijesh, you're not audible.
Hello.
Yeah.
Dr. Brijesh, you're not audible.
Hello. So next is prospective evaluation of artificial intelligence triage of intracranial hemorrhage on non-contrast head CT examinations. So normally, to what they have done is that they have used retrospective studies to evaluate AI algorithms for intracranial hemorrhage detection on non-contrast CTs. The methods they have used, this was a single center study which included adult patients who underwent non-contrast CTs between May of 12th, 2021 to June 30th, 2021, and from September 30 the same year to December 4th. So the radiology department, they implemented a commercial AI trial system for ICH detection, and that processed the head CT examinations and notified the radiologists positive results through a widget with a floating pop-up display. Now, these examinations were then interpreted by the neuroradiologist or the emergency radiologist, and the comparison was made with uh, with and without AI in both the phases. Now, a panel of radiologists conducted a review process for all these examinations, and the with discordance between the radiology report and AI and the subset of the remaining examinations to establish a reference standard. The diagnostic performance and report turnaround times were compared using Pearson's chi-square and Wilcoxon ransom, and the diagnostic performance metrics were checked with Bonferroni correction. Now, what they have determined is that out of the total 9,954 examinations from 7,371 patients, in those, around the AI trial system for intracranial hemorrhage detection did not significantly improve the radiologist's diagnostic performance or the report turnaround times. The mean reported turnaround time for ICH positive examination around 147.1 without AI versus 149.9 minutes with AI. Over to you, sir.
So I think on this, Dr. Rahul Vakharia can help us throw some light on the same, or Dr. Abhijit Raut. Do we have Dr. Rahul Vakharia over here?
Hi, can you hear me?
Yes, we can hear you, sir.
Yeah. So the acute hemorrhage is, I mean, it's very easy to pick up and it's very difficult to miss. So that's how the results are that the AI is not going, I mean, it's not helping us or it's better than us. Even a small hemorrhage, if with a proper clinical history, it's unlikely that any trained eyes would miss out on, or even a 1 year experienced radiologist can miss out on the hemorrhage.
True. So how do you think, sir, AI would roll in this and AI would help, according to you? Do you think it has any role in it to help in future?
It appears less likely that AI would be of any help in hemorrhage. It might help us in the infarct part if it's very early, but hemorrhage less likely it would help us in this.
True.
Particularly to decide the type of hemorrhage, because it can be an arterial hemorrhage, can be venous hemorrhage, or traumatic. We don't know. So a specificity it would be a little difficult.
Maybe it can quantify.
Yes, quantification can be done easily.
Yes.
Can I add a point?
Please,
So,
sir, please.
yeah, so I'm working at Narayana Health, and so Narayana has almost 25 centers across the country. So what they have done, they are running a pilot project at Bangalore unit where and as rightly pointed by Dr. Rahul, that it is more so for the infarct part. So all patients who come with a diagnosis, or let's say a query of an ischemic stroke, all MRs and MR perfusions which are done, they are directly sent to the central unit because it's connected everywhere. You get a report within 10 to 15 minutes, which is AI generated, right? Which is the software they're doing a pilot project about what is the status and the perfusion. See, I'm not a radiologist, so I may not be talking in very much of technical terms, but this is what we get as a report, and within 15 minutes we get a pop-up that this is the finding. The radiologist also sees the report in terms, they're both independently seeing the scans, and on the basis of that the final decision is being taken. So on an average they are running through almost like 120 scans a day, right, for all MR angios and TOF and perfusion scans just for the stroke. So I don't know the data as of now, but this is what is being done in my hospital.
So let me just add on a sentence to this. We have a software called Rapid Software in our hospital, and what we have realized is it doesn't pick up a small stroke, or it cannot even infarct. I'm talking about not the hemorrhage but the infarct. Small strokes are missed quite frequently, and you cannot just reliable entirely on the AI to treat your patients. I mean, at least a radiologist or the person who is in the department at that point of time should be, having a final word on it.
So I don't know the result of what they are doing with the pilot project, but this is what is being done right now. What
Yeah,
I know.
it's done around the world. So this is a good thing that is happening in India also.
I think there is much role to explore of the AI on that basis, and if it is done on such a large scale, I think we look forward to it. Maybe in the future we can get mainly not for the plain ICH that, like Rahul Vakharia sir rightly said, that can be easily picked up. But at the same time, I'm sure there must be many other algorithms in which we can explore, in which AI can be helpful, especially in terms of stroke. But at the end of the day, we can always have a parallel system in which it can again be cross-checked by the radiologist. That would really help.
Absolutely.
Yes. So thank you, Dr. Sachin Gupta again and Dr. Rahul Vakharia for
Thanks.
adding to it. We can go to the next topic, Dr. Ritika.
Next, we have a AGR expert panel narrative review regarding integrating theranostics into the coupling of a diagnostic biomarker and a therapeutic agent that have a common target in tumor cells or their microenvironment. So even though this term was coined in 1988, we have been applying this since 1940s with the radioactive iodine. This term is increasingly associated with in vivo nuclear medicine, oncological applications that couple diagnostic imaging by means of gamma radiation with concomitant localized high energy particulate radiation to a tissue. So this is a figure which basically shows how the mechanism of action is during theranostics. And this is usually available for metastatic disease which fails to respond to well-established systemic therapies like conventional chemotherapy. Now we have been using this for thyroid cancer, neuroendocrine tumor, prostate cancer in adult pheochromocytoma, and paraganglioma. Using iodinated radioactive iodine. And for neuroendocrine tumor, this imaged with gallium-68, and it's treated with the lutetium dotapeptides. For prostate cancer, we are using technetium hydronate and sodium fluoride, strontium fluorides, and the EDTMP. For adult pheochromocytoma and paraganglioma and pediatric neoblastoma, we are using MIBG. Now, integrating this with current treatment, there are other issues, emergencies which occur during the use of this. Like for lutetium dotatate, when we're using it, there can be hormonal crisis and there can be tumor lysis syndrome also for high turnover cancers. In MIBG, there can be a catecholaminergic surge. For when we're using lutetium dotatate, we have to manage by using octreotide bolus, by using H1 and H2 receptor blockers, steroids, and sometimes these patients may require ICU transfer also. Lutetium dotatate, as it can cause tumor lysis syndrome, so we have to identify the patients who are at risk factors for that and consider rehydration for them. And if they have an elevated uric acid levels, we can consider allopurinol preemptively. And for MIBG, we can start a slow infusion of alpha or beta blockade to prevent any complications after using this. What do you say?
I think Dr. Karuna ma'am would be the best person to throw some light on the same topic.
Yes, good evening, everyone. So first of all, just just going back to the previous slide, I wanted to say that see, thyroid cancer therapy we've been doing since 1942, but for neuroendocrine tumors, we give PRRT with lutetium dotatate or also actinium-225, which is the alpha emitter, actinium-225 dotatate. For prostate cancer, I think this paper is from America where they use a lot of sodium fluoride, which is specific only for bone metastasis. But what we use, and in Europe and Australia, what the major use has been is of PSMA targeted therapy. So we image the disease using the gallium PSMA PET, and we treat it using lutetium PSMA, which goes to soft tissue as well as bone metastasis of the disease. And typically, after the first line hormonal therapy fails in metastatic disease, when the disease becomes castrate resistant, that is the ideal time when the patients, should be or are treated with this lutetium PSMA therapy. And pheochromocytomas, paragangliomas, again, either you can treat them with I-131 MIBG or also with lutetium dotatate therapy or the PRRT. So just that about this thing. Then we go to the next slide again. Yeah. So where we are careful or worried when we are giving PRRT, I think there have been occasions in the last 1 or 2 years when I have requested that the patient during the infusion should be in the ICU, is when we have a functioning neuroendocrine tumor, particularly those which have a history of carcinoid syndrome in the past. Now, carcinoid syndrome typically occurs in NETs which arise in the midgut, and those which have a very high liver burden of disease, because then the peptides or the serotonin and other amines which are produced by these tumors cannot get metabolized because the liver is already studded with metastasis, and they bypass and enter into the systemic circulation, causing the carcinoid syndrome as well as the carcinoid crisis. And though we do have a kind of a screening tool that obviously a patient who has had a history of a carcinoid syndrome in the past, we are more careful. And what we do measure is the urinary 5-hydroxyindolic acid 5-HIA levels prior to planning the PRRT. But the strange thing about carcinoid crisis is that even in a previously asymptomatic patient who has never actually presented with the typical symptoms. The only patient I have actually had once of a carcinoid crisis was one such patient who never had carcinoid symptoms in the past. And after PRRT, he, within an hour or so, he developed a carcinoid crisis. So it is a bit unpredictable what triggers this crisis. So that is the reason why we are usually prepared for any patient where we are giving PRRT. We always keep the cold octreotide as a standby, because if we see that the patient is manifesting any of the symptoms, we immediately give a bolus of the cold octreotide, which goes and blocks the receptors, kind of controlling the situation. And that is for these functioning carcinoids. Secondly, when we have functioning pheochromocytomas or paragangliomas, over there again we have to be very careful, because when we give the infusion, because of the acute effect of radiation on the tumor, there can be a release of catecholamines, and this again obviously we would need the help of the ICU team for close monitoring. Again, my experience with this situation has been that sodium nitroprusside has been, as an infusion, was very useful. We had a child with a paraganglioma, and sodium nitroprusside infusion was kept on because the patient was at baseline only, very hypertensive. And then phentolamine bolus has also been advised as a method of controlling this hypertensive crisis. And then, of course, I guess the ICU team is best to tell us that what will be the drugs which they will use to control the hypertension, the tachycardia, etc. Third situation is the tumor lysis syndrome, which occurs because when we give this radionuclide therapy, these are patients who have extensive metastatic disease. And because the radiation causes such a significant effect on the tumor and there's a huge volume of tumor, sometimes there can be a release of the tumor cells into the system. So we monitor the electrolyte levels. We insist on good hydration. So the reason why we admit these patients for the therapies for lutetium PSMA is because whole day we give them a good level of hydration over 8 to 10 hours. Once they are discharged also, we make sure that they are well hydrated. And we have to be careful, advise them on discharge that any symptoms of cramps or dark urine or any kind of, unusual this thing, they must report back immediately. So that is our usual practice when we are giving these therapies.
That was extremely informative, ma'am. Thank you so much, ma'am, for explaining to all of us in so much depth and detail. Does anyone have any questions, or we take it to the end? So going forward, we go to the next topic, Dr. Ritika.
Yes. So this is our next topic, update on gadolinium-based contrast agent safety, again from the American Journal of Radiology. So as we all know that gadolinium is paramagnetic at room temperature, and it is considered relatively safe MRI contrast agent, but definitely it is also having its own side effects, and most important that we all are aware about it is nephrogenic systemic fibrosis. Along with that, there are other like acute allergic reactions and gadolinium depositions. So we need to know which are the patients who are at serious risk of this nephrogenic systemic fibrosis, and they are with the patient with kidney failure and those who patients on renal replacement therapy. So it is because of the dissociation of the free and toxic gadolinium. Then there are group 2 and 3 gadolinium-based contrast agents considered lower risk, and through their use, NSF has largely been eliminated. So there are studies showing that there is a trace amounts of gadolinium that gets deposited in the brain and other organs, has been recognized for over a decade. And deposition occurs with all agents, although linear agents appear to deposit more than macrocyclic agents. But definitely no data show any adverse biologic or clinical effects from gadolinium deposition, even with normal kidney function. So this is one very simple flow chart that is described that whether the patient referred for MRI, patient is on dialysis, increased risk of nephrogenic systemic fibrosis, then we need to schedule the hemodialysis as soon as the MRI is done with the gadolinium-based contrast agent. And there are few general principles to minimize this risk. So I would like to discuss on this, that how we can make it more safe for the patients who are at risk for this severe complication. And how severe it is in the now with improving contrast agents. So now the risk is same as it was before?
If I may ask, thank you, Dr. Ritika, for the lecture. And if I may ask Dr. Rahul Vakharia, sir, and Dr. Abhijit Raut, sir, to throw some light on the same. Dr. Abhijit Raut. Do we have him?
Just ask, sir.
Do we have Dr. Rahul Vakharia?
Yeah. So basically, gadolinium is a very safe contrast. But anything with, after all, it's a contrast. So the patients who are having renal dysfunction should be avoided as much as possible. But if we have to do it, we can go ahead and hydrate the patient, and then as what Dr. Ritika said, that if the patient has to be dialyzed, when post contrast, the study should be planned in such a fashion that post contrast the patient can go for the dialysis.
Okay.
Hello.
That would be helpful, sir.
Yeah, that's it. Gadolinium is relatively safe. We have not seen, I've been practicing since last 25 years, 25 plus years, but we have not seen NSF up till now.
Okay, sir.
So that kind of.
Yes, sir. So, from the clinical or medical legal point of view also, if suppose any CKD patients going on hemodialysis, going for the MRI with requiring gadolinium contrast, do we need to explain these complications that because if definitely we need to see the risk and benefit?
Yes, we need to explain the risk.
Yes, sir. Got it, sir.
Yeah, okay.
Yes, sir. Thank you, sir.
Thank you.
That was quite helpful. Thank you, Dr. Rahul Vakharia, sir, for throwing this light on that. Can we move on to the next topic, please?
So it is just one a few lines I have included because we should not miss on this radiology part, this role of point of care ultrasound in critical care and emergency medicine, and definitely update and future perspective, because focus, it's a rapidly developing technology and has potential to revolutionize the emergency and critical care medicine. It is now getting very handy in all the ICUs, and it is now called as a stethoscope of the doctors in the critical care. So use of focus, it can improve patient care by providing real-time clinical informations. And now doctors are getting trained on that. So we can do it without having much time lag. But appropriate usage and proper training are crucial to ensure patient safety and reliability. So just Dr. Dhaval, Dr. Rahul Sheth, sir, if you're there, so throw some light on that how it is changing our practice in critical care medicine. Because you also are getting the calls that if...
Yes. Do we have Dr. Rahul Sheth, sir, to throw the light on the same? So from what I understand, there are few indications in which we can actually make a difference by just like, be it if the patient has any hemothorax, we do an X-ray and we want to rule that out. If we want to rule out any pneumothorax, or if the patient is in shock, hypotension, we want to immediately see the IVC if it's collapsed or not, and accordingly, immediately we can give a bolus dose in cases of any aneurysm or anything like, this. So this is going to be the next best thing possible, because
So can I
everywhere
add?
we,
Yeah.
yeah, please, Dr. Sachin.
So see, because now, so most of the ICUs now have a dedicated ultrasound machine at their disposal. We are running a 1 year fellowship course only for POCUS, which we name as FCCUs, which is only for the ICU part. It's a 1 year fellowship course which the Indian Society is running, where we give them the complete training from a head to toe ultrasound evaluation, which is relevant to critical care. We are not radiologists. We don't intend to become a radiologist, right? So let's say if I have to talk about head, we look at TCD, then we look at our basic echoes, we look at the lung ultrasound, we look at the abdominal scanning, the fast scanning, initial DVT assessment. How does it look like pulmonary embolism, so on and so forth, and for the vascular access and other things. So POCUS has changed. So people who are practicing POCUS, for example, my ICU, it's a mandate to have ultrasound during the round. So every patient is being rounded with the help of an ultrasound on a daily basis to assess what is the status of the lung. If we have seen it yesterday, what has changed from yesterday till today, right? So people who are using it, they have actually forgotten how to use a stethoscope. I will put it this way, because you get that visual acuity, and you are very good at picking up things, and it does not have a very steep learning curve. It has a shallow learning curve. If you are really good about it, you can we do all kinds of radiological interventions. I accept the vascular interventions. For example, in my unit, we are doing all intervention in terms of pigtail drainages and so on and so forth. So it's about the adaptation, and POCUS has changed the way the ultrasound management is done when it comes to shock management, when it comes to respiratory distress management. So it's a boon which we have nowadays.
That was extremely wonderful, Dr. Sachin Gupta, sir. And genuinely, maybe if in our hospital as well, we can start that kind of fellowship. But I think that is, like you precisely said, it can actually be an adjacent thing to stethoscope. Like, it is so much convenient to check something so important and so conveniently, and the visual acuity that is being given, it is so precise. So I think that is going to be, and it's going to be of relevance in the near future as well. The use is only going to increase with time, I can understand. And like you precisely said, if it is a shallow curve, we should train as many people as possible to look for these things, and it really helps us to
Just
get.
to add, the relevance of ultrasound in critical care is in the year 2000, a very senior intensivist had put an ICD, right? And the
I
patient
know.
probably had a complication and died because of that. In 2020, that is 20 years later, the judgment was passed that why was the ultrasound not used while deciding where to put the ICD. So this is the relevance of ultrasound in critical care. This is what I'm trying to put at it.
True. That was very helpful, everyone.
The lawyers also understand the relevance, so it is very, very good. And see, most of the quality indicators, see, right now India does not have that rule, but if you go to UK and other stuff,
Yeah,
there
they
are
have their
these nice
protocol.
guidelines where without ultrasound you can't do a procedure. Your license would be taken away from you.
Right.
True. So that
Right.
was extremely enlightening and helpful. Thank you, Dr. Bijesh and Dr. Ritika, for the entire session. Thank you, Dr. Rahul Sheth, Dr. Sachin Gupta, Dr. Rahul Wakharia, Dr. Abhijit Rahul, Dr. Karuna Lutharia, ma'am, everyone. And thank you, Dr. Arindam Kaur, for letting me moderate this session.
Thank you so much. Good night.
Thank you so much,
Thank
sir.
you.
Thank you, everyone.
for
I
joining
think
us.
we had a wonderful 4 different sessions. We will be back tomorrow, same time, 5 p.m. onwards. And I hope we will have similar sort of enthusiasm from the presenters, moderators, as well as good insight and inputs from all the clinical experts. So thank you and see you tomorrow. Have a nice night.
Thank you, sir. Good night. Bye.
Thank you, sir. Good night, everyone.